Hello, everyone, and welcome. We're getting started right at 1 o'clock. So as I said, we do have a live stream going on Facebook, which is a new addition for this. I want to welcome you all to the Delaware Center for Health Innovation Cross-Committee meeting. I think this is the 5th of these events over the last 2 years. And I'm happy to see that it continues to be such a strong platform for stakeholder engagement and, most importantly, your feedback. So we're looking forward to that today. Our live stream on Facebook will have an additional audience, and we welcome questions and feedback there via any social media channel at DCHI Engage, hashtag DCHI Engage. I'm going to keep my comments brief because we have a packed agenda, as you know. And I just wanted to start by giving a reminder of why we're all here. We've got a healthcare system in Delaware that is delivering varied outcomes across the state. And while there can be some discussion about what areas are working better than others, there can be no argument about the unsustainable path that we're on in terms of cost. And that is the threat to all Delawareans. Through our work at CMMI, we've targeted the triple aim, lowering costs while delivering better care and better health, plus our own addition, provider experience. And DCHI's role in this healthcare reform is to serve as an effective conduit for the voice of Delaware stakeholders to reach the state administration. And by convening the broad and diverse community of key stakeholders and discussing statewide needs and strategic solutions, continuity and momentum to the work, and be an aggregator of influence for the development of state policy and advocacy. So even during the gubernatorial transition, we were very encouraged by the level of engagement with DCHI and the interest that the new administration took in what groundwork had been laid over the last 2 years in the realms of practice transformation, healthy neighborhoods, workforce development, technology initiatives, and of course, payment reform. And since then, the level of collaboration has certainly been welcomed, and like the event today, which was jointly developed with the DCHI, Department of Health and Social Service, and the Healthcare Commission, we are all embracing the opportunity to take advantage of the foundation that has been built, and we can now accelerate the work. In that spirit, I now have the pleasure of introducing Secretary of Health and Social Service, Carol Walker.
Thank you so much for being here. Thank you to Matt for helping us launch this very exciting event. It's wonderful to see stakeholders from across the state who are passionate about improving healthcare in our state of Delaware. I'm just going to set the stage for today's event, but I do want to say a special thank you to both DCHI Cross-Committee leadership for helping us bring together thoughts and ideas in this agenda. I also want to say a special thank you to Laura Howard from the Healthcare Commission and to Stephen Costantino, who assisted in putting together this panel. I want to remind everyone where we are in our beautiful state. We currently are in a situation this last week of the legislative session trying to figure out how to get to a budget. And certainly healthcare costs are contributing a large portion of the real need to figure out how we do things differently, especially in healthcare. 25% of the costs in the state's budget are due to healthcare costs, and we know that that number is growing, right? That percentage is really pushing out other programmatic needs. We also know that our demographics in the state, the number of people who come here to retire and the aging population continues to grow. That's going to continue to push to think about how we organize care and how we think about steering people towards appropriate sites of care in greater proportion going in the future. We also know that we have a very unique environment. We have a very wonderful set of hospitals who are very collaborative, but we also know that our provider landscape is quite concentrated in Delaware, more than in most markets. And that makes us unique. We can get everyone in the room, but we definitely have to figure out how to collaborate and coordinate in different ways. And we also are trying to figure out how to make sure that we have primary care that's well coordinated and serves as an input and a way to really create medical homes for every patient in Delaware. We have a huge need around the addiction epidemic that's facing our our state right now, and we need more work around integrating behavioral health in all that we do. So this is our landscape. We certainly have also looked at what we look like across the country in terms of per capita costs, and based on a recent release of CMS data, we are actually number 3 in terms of per capita costs in the country. That is certainly something that we need to see and look at and make sure that we're doing things differently. Again, we have to figure out how to change that dynamic and what it means and where the cost drivers are and how we can start to use this as momentum to make sure that we're paying for things that are value-based and outcomes-based and based on high quality, particularly when we have high costs in our system. We also know that in the state's budget, there are many things that we have to look at. So when you look over a 6-year period, we have had a growth in the healthcare segment of our state budget that has grown, and that's what we do in state employee health and correctional medicine for retirees and for Medicaid. Across the board, we're trying to figure out how to contain that growth, and there are different strategies we'll hear about today from our very illustrious panels. And I'm so excited to talk more about how we can solve this problem collectively, driven by the healthcare community itself, and with the work of stakeholders to come at the table and talk about solutions. We also know that there are many drivers of healthcare spending in our state, particularly we could think about things about hospital-based care, what we're doing in nursing homes, what we're doing in hospitals, but we can also look at how using ER and the emergency department usage is driving up some of those costs as well. And that's just one of the many factors that we should explore that's unique in the Delaware marketplace. We also have a very unique set of drivers around specialty-based care that also puts us at the higher end above average, and I bet if we had more updated information, this would also be something we could think about together. How do we sort of rebalance some of the work that's being done that allows primary care to be the center of focus and really funnel in more appropriate and avoid things that are unnecessary or inappropriate uses of care. So this is just a bit of the data that sets the stage for today. I'm hoping that today's panel will really engage us around a conversation about how we use data-driven approaches, how we think about cost and utilization, and we're certainly proud that we've made a significant investment in how we transition to value-based payment models through the work of DCHI, through exploring different models that exist in other states and other places, and we're trying to learn those lessons so that we can create something that's unique to the state of Delaware. Overall, about 30% of Delawareans are currently attributed to providers participating in value-based payment models. That's a great step in the right direction. We have to take that even further and continue to make investments to make sure we're thinking about delivery system reform and provide incentives to providers in the community. We know that voluntary adoption models for payment reform are really hard. They're really hard and they go slow. And so anything we can do collectively to push that, make it easier for people, make it easier for providers, make it easier for hospitals, we want to start thinking about this. So, given that context and the setting of where we are with the state's budget and the budget crunch that we're currently dealing with right down the street right now, this is certainly the time to think about healthcare. And so I am just very pleased for the opportunity to hear from everyone today, hear from our guests, and turn it back over to DCHI.
Thanks, everyone. My name is Tom Brown. I'm with Delaware Health Services, and more importantly right now, I'm co-chair of the payment committee for DCHI. For those of us who have been in the room working on payment reform over the last few years, today's an exciting day because we have speakers from 3 states which we've heard a lot about, Vermont, Massachusetts, and Maryland, who have 3 unique approaches to payment reform, and we're really pleased to have our speakers with us. Please join us up here, our speakers. What I will do is introduce all 3 speakers. Dr. Sharfstein from Maryland, he's got a previous commitment, so he's going to have to leave quickly after he speaks. We'll also be taking questions after all 3 panelists have a chance to speak. Our first panelist, as I referred to, is Dr. Joshua Sharfstein, who's the Associate Dean for Public Health Practice and Training at the Johns Hopkins Bloomberg School of Public Health. Previously, Dr. Sharfstein was the Secretary of Maryland's Department of Health and Human Services and Mental Hygiene in Maryland from 2011 to 2014. And during that time in his position, he helped navigate Maryland into a payment system for all hospital care for Maryland residents. So we'll be speaking to that. He also oversaw the development of a health improvement process with 18 local public and private coalitions and the reshaping of the state's approach to information exchange, long-term care, and behavioral health. Our second panelist is Robin Lund from the Vermont Green Mountain Care Board. She's a member of the board who is charged with designing and administrating the state's health care payment system. And as we've talked about many times, this is a unique approach that has been very effective up in Vermont. And we'll be asking her a lot of questions about how they got it kicked off. She's currently she worked as a senior policy advisor in DC on public health, and she's an expert in public and benefit programs, healthcare, and healthcare reform. Our third panelist is David Seltz. Mr. Seltz is the executive director of the Massachusetts Health Policy Commission, and he is in fact the first executive director of this commission. He was the chief healthcare advisor to the legislature and to the governor as they formed their reforms in the state of Massachusetts. He's advised the passage of many healthcare bills that led to reforms in Massachusetts in 2012 and I think it was 2005? Six. Okay. So anyway, we're pleased to have all three of them with us. So I'd ask first for Dr. Starkey to join us.
Thank you so much, and thanks certainly to the Delaware Center for Health Innovation, the Delaware Healthcare Commission, and especially to Dr. Walker for having invited me. What a great initiative you all are part of, and personally want to say how exciting it is that Dr. Walker is up here and is assembling such a great team, and the governor too, Steve Constantino, and others. It's really putting Delaware in a great position, and I certainly pick up a lot of buzz about Delaware. So it's great to be here. And I very much apologize that I have to run out early, but I am not too far away and available in the future for whatever consultations or questions might come up. So Maryland is a pretty unique state, but we're very close by. And so to understand what's going on in Maryland, and there's actually a bunch of things that stretch across the border, is pretty helpful, I think, for your understanding what might be possible. So I'm going to talk about global hospital budgeting in the state of Maryland. So, important to understand Maryland's different from all the other states in one way, which is that Maryland has a rate-setting system for hospitals, which means there's an independent group appointed by the governor, confirmed by the state senate, that meets and sets rates for what the hospital is allowed to charge, and every payer pays the same. So this is obviously very different than what exists in Delaware and every other state. This has existed since the 1970s. Essentially, every hospital receives a rate card, and everyone pays off that rate card. And it's been, a very helpful system for Maryland in a lot of ways. We don't have cost shifting between payers. We don't have all this energy being spent negotiating rates. And it takes care of medical education. There are a bunch of things. It's very good for uncompensated care because all the costs get pooled. And there's essentially like a 6 or 7% charge on every hospital bill. All the money goes into a pool, and it goes back out to where those uncompensated care costs have accrued across the hospital system. And just to understand what that means, it means that in Maryland, we set the rates that everyone pays, including our Blue Cross plan, our Kaiser plan, as well as our Medicaid plan and the National Medicare program. So Medicare pays Medicare rates in 49 states and the District of Columbia, including Delaware, and Medicare pays Maryland rates in Maryland set by the Commission. But there was a condition placed on that, which is Medicare will only pay the rates in Maryland if everyone pays the same, can't increase the rates for Medicare. And if, under this law, if we were able to keep our price growth per admission under the national increase in prices, but it turned out we couldn't really do that so effectively, and that created a crisis just about the time that I became health secretary. So what that meant was we might lose this whole system, and everybody started running around wondering what we could do, and we had an opportunity. So when Dr. Walker talked about the challenge that you have with the state budget, that is another way, an opportunity to think about how to do things a little differently. We took the challenge that we had to think about paying hospitals differently through our rate setting system. And what we based this on was a pilot that had been in effect for a few years before I became secretary. And the pilot is, going to blow your mind right there. Okay, the pilot was we gave these rural hospitals, 10 rural hospitals, a budget in advance of the year for all payers, all patients, no matter who came in. If people came in, they got the same budget. If people didn't come in, they got the same budget. And that's how much money they were going to get. It didn't require the hospital to keep the beds filled in order to get paid. They were going to get paid the same amount no matter how many people came in. And so our governor, Governor O'Malley at the time, said, so we're going to stop paying hospitals like hotels. And we said, that's right, we're not going to pay hospitals like hotels anymore. We're going to pay hospitals a set amount, and that gives hospitals the incentive to prevent illness. And we did this in these 10 hospitals, mainly rural. How we did it with our rate setting system is probably something we could explain, but we adjusted the rates. But in the end of the day, it didn't matter how many patients came in for that year. They knew what their revenue was going to be. And so we went from a volume-driven model where we used rate setting to give a rate card, and it was just fee for service, but everyone paid the same rates, to a budget in advance that the hospital knew how much they were going to get. And I learned this, I'll tell you how I learned this. I was minding my own business. Again, this had started a couple of years before. I was sitting there trying to figure out, where the bathroom was in my office. And 4 rural hospital CEOs showed up in my office and demanded to know why we didn't have better mental health care for chronically ill people with mental illness. And I thought it was like candid camera. I'm like, you're a hospital CEO, why do you care so much about this? I didn't even understand what was going on. And then they sat me down and they said, you understand we have a global budget. We looked at our data. Half of the people who keep coming back to the hospital have chronic mental illness. It's time we got these people, the services they need. Because if they, I think they genuinely wanted to get the people the services they need. And it was also the case that if fewer of them came to the hospital, they kept their budget, right? It was better for them. And I learned from the different behavior of the healthcare system that something fundamentally different was going on. And so hospitals get this budget, and they can use that money in different ways. They can use it to support primary care. They can use it to support community interventions, better care coordination. I visited this hospital in Western Maryland, and I walked in and I walked out because I was confused that there was nobody in the lobby, right? The hospital is 50% full. I was, didn't know what was going on. The CEO came over to meet me, just sort of skipping his step. And I thought, like any other hospital CEO, 50% filled, you're brushing up your LinkedIn profile. That's not a good thing, right? He was so happy. He had been the CEO under fee-for-service, straining to keep beds filled. Where can we find more patients? Where can we get more hearts, more lungs, more kidneys? Now, it's like, where can we prevent disease? And he had set up a system where every time they discharged a patient to a nursing home, they sent the person, a nurse out twice. He created a clinic for everyone in the county with heart failure, diabetes, asthma, pharmacists, nutritionists, all to support the patients. They had closed wards of their hospital. They just didn't need them anymore. And he said we went from a campaign where we said, Western Maryland Hospital, always there for you, to, he called it the unofficial motto of, we hope to never see you again. Okay, and that's what happens when you switch the incentives. And these are some of their slides about Western Maryland Hospital. I'm not going to go through them all, but basically they did a whole bunch of different strategies. Some of their strategies involved doctors, some of their strategies involved community and clinics, other things, and in the end they had a 25% drop in inpatient admissions, a drop in readmissions, a huge drop in behavioral readmissions, a drop in ER visits, and health improved in their county. New York Times wrote a story about the small rural hospital. And now when I hear from the CEO, he just tells me where he's going. I'm talking to the American Hospital Association board in Hawaii. He's very excited. He's very much in demand speaker because he had to totally transform his institution because the payment changed. Fee for service is not aligned with better health outcomes and lower costs. If the beds have to be filled, you need sick people. It's just really hard to swim upstream against that. You go to a global budget, the hospitals become allies in everything else you want to do in the healthcare system to reduce costs because they get to keep some of And so there have been a whole bunch of different community collaborations. I'll just tell you one last story. So I don't know, in case there may be one question for me or something. So I'm minding my own business. That's what we do when we're secretaries of health. I'm sure we just minding our own business in our office, And somebody comes running in and says there's a big fight between the school system and the health department in Washington County, Maryland, which is one of these counties where they started with this program, and that all the school nurses have been fired. And the health commissioner out there is upset, and this is now my problem. And I'm thinking to myself, okay, great health commissioner, see what we can do. And in the middle of all that, I get a call from the CEO of the hospital. And I talk to him and I say, so what's going on? He goes, well, I just want to let you know we're going to hire all the school nurses. He's a little bit of a drawl. I can't really do it. I think we're just got to let you know we're going to hire all the school nurses. I'm like, why are you doing that? And he said, well, we're one of the TPR, one of the global budget hospitals. And we looked at our data. We have so many kids coming to the hospital for asthma. And we thought, we can run the school health program at break even. We can really focus on preventing asthma. And we'll save so much money on the back end. And I was like, that makes sense. And why do we pay hospitals more everywhere else when more kids struggle to breathe? Why? If that's possible, if hospitals can really be part of the solution, can we reward them for that? Can we think about doing things differently? And eventually what we did is we took this rural model and it became a model for the whole state. Every hospital now, the urban ones, the rural ones are on the form of a global budget. Very important to be successful, you have to use electronic data. All of our hospitals coordinate through the Health Information Exchange. The Delaware's Health Information Exchange is built on the same technology. You can be doing all of those things. Any primary care doctor in Maryland can get a panel, shows the instantaneous, the up to the second hospital utilization of their panel of patients on the website. There's just all these different services, real-time notifications that are happening. All that supports the collective enterprise. When you do this and you set global budgets, all the hospitals want to work together. They want to find those patients who are going in and out and costing a lot of money and not doing well, and they want to make them, healthier. Let me just, this just shows how we use a lot of data in Maryland and how the system works and how it's very helpful to see data for the whole state. And we can actually use that data to track different health outcomes and inform public health practice for things like overdose and dental. Our project has been called by prominent health economists the boldest proposal in the United States in the last half century to grab the problem of cost growth by the horns. Maybe Vermont is bolder, but they're getting started. We're a couple years in. Very impressed with Vermont, and just a couple results. So far, I think we've saved over $400 million in Medicare alone compared to the national cost growth in hospital costs. And if you look at net Medicare expenditures, it's more than $300 million in the first 2.5 years. And there have been tons of benefits as well to the private payers and the private employers. We've also had a 48% reduction in potentially preventable conditions inside the hospital and a major reduction in readmissions. And so let me pause there. Let me just point out one question that always comes up. Well, if you pay someone a global budget, then why should they keep caring for patients? I once gave this lecture in an area where they were building a $4 billion fee-for-service hospital outside the window, and so they didn't understand really what I was talking about with global budgets. And one person said, I'm going to go to Maryland. I'm going to become a hospital CEO. And I'm going to just charter a bus and send all my patients to another hospital. And I'm going to make all this money under a global budget. Well, the way it works is you have a budget for the year. If you prevent illness, like through that school health program, you keep the money the next year. But if there's a market shift and your patients are going somewhere else, your budget will be cut the next year. And so we have a director of that commission that pretty much looks at the hospital executives, and says, I figured out all your games before you even try them. And the hospitals realize it's much more effective to actually do the right thing. And the hospitals are very excited about being a part of the solution. The flip way to think about this is that right now, if a hospital wants to do what that CEO did in Meredith's health system in Washington County and take over the school health system and really drive down their preventable asthma admissions, it will cost them money in their bottom line. And so you're asking people to do something averse to their financial interests. You line up those financial interests, And all these great things can happen. People say things like, this is why I went into medicine, this is why I went into hospital administration. This is a great thing. It's better healthcare, better health, lower costs. And I would certainly encourage Delaware to think about global budgeting for hospitals as one part of the solution to the problem that you're facing. Thank you.
I'll give a moment. Are there any questions very quickly for Dr. Sharkey? Please.
What is the breakdown between for-profit and non-profit hospitals? And I used to live in Washington County.
Oh, okay, good. We have all nonprofit hospitals.
All right.
Anything else?
What if I say that Delaware has sicker patients than Maryland, and we have a aging population with a lot of chronically ill patients? How does that factor in here? We still need admissions to the hospitals, and that makes our budget really good for that year.
So the question was about, well, what if we have sicker patients? And so, and a lot of chronic illness. You know, there's actually, one way to think about it is that there are more opportunities the sicker the patients and the more chronic illness. It's important that these budgets be set at the right level. Let's stipulate we can set it at the right level. And now you got a budget, right? It's if you did nothing and they all came into the hospital, you'd be able to cover it. You'd be fine. But you don't have to do nothing now, right? You could use some of that money to actually help them. And there's so many patients, when you start to look at it, how many patients keep coming back to the hospital? How many people with heart failure go home and have a pizza during the game and they bounce right back in and they don't have other options? And when you flip those incentives, someone in the hospital is going to say something like, no, we could do something a little bit differently. And the health department can play a role. You know, there's so many different things. Even if the hospital did nothing, but just stood to benefit, then the hospital would be much more engaged naturally in all kinds of community health activities. And you may know, hospitals have community benefit plans that they're nonprofit, and oftentimes those community benefit plans are a little bit, out there. I was not in Maryland, not in Delaware, another state. They said, well, our community benefit plan used to be that the head of community benefits judged the state beauty pageant. That's not maybe in the top 10 of evidence-based interventions, So, but then you go to a system where, okay, the hospital stands to benefit, just that very fact, if the people with chronic illness get better care, then wait, let's pull in the community benefit plan and say, let's try something different. Why don't we do something that's really going to have an impact?
We have a lot more questions. Dr. Arstein does have to get going, but I'm going to ask one.
Okay.
Quickly, what obstacles do you see coming down the pike now the program before it was about 3 years old? Do you see any?
I used to say to the doctors, the one thing I can assure you in advance is that there will be no unanticipated consequences. Of course, there are all kinds of challenges in Maryland. And actually, alignment with the physicians has been a big challenge because while the budgets include the hospital costs, they don't always include the physician salaries, and there are a whole range of activities to set that. Maryland is actually revising the model to include physicians a lot more. I think that that's probably the single biggest one. The methodology for how to do that market share adjustment that I talked about is a very important part of doing this. There's a technical aspect of it because you want to really make sure you're rewarding hospitals that are doing a better job and getting more patients. So, because they're choosing to go to that hospital, you don't want to remove that basic incentive. At the same time, you're rewarding them for prevention. So how to do that well is a technical challenge. So I think there are different challenges. I will say that fundamentally, the health system in Maryland supports this. All the hospitals signed on. It gave them a lot of stability. It gave them new business avenues in terms of prevention. A hospital CEO said, Josh, for me to get 1% margin, think profit, but it's a nonprofit. For me to get 1% margin, I have to do 5% more volume. I have to find 5% more volume. But if you give me a budget, I can just prevent, and I can get that 1%. And it's so much cheaper to you. You don't have to pay for the whole 5%. So there's really a opportunity to do different types of engagement and bring people along. I do think that Maryland is finding its way in a lot of ways. The point I wanted to make though is that even with the changes in Washington, I think that crazy not to support because they're pretty, we did this in Maryland without a lot, there's plenty of discussion, but when the dust settled, everybody really stood behind it because it made a lot of sense for the state, and I think it's definitely within the realm for Delaware. The last thing I would be remiss if I didn't say is that while it was easier for us to do this with rate setting, it doesn't require rate setting, and in fact, Pennsylvania got a separate model and $20 million from CMS to launch global budgeting for rural hospitals. And they're in the middle of planning that 30 rural hospitals over 3 years. So between Maryland and Pennsylvania, we're a lot closer than Vermont and Massachusetts. So that's not You're going to have some fabulous presentations. I'm sorry I have to run.
Give you a little disclaimer. Before coming to Delaware, I started my healthcare career in Maryland, and I was dumbfounded that we had to negotiate rates. I was like, what? I never heard of such a thing. It was a nice place to have been. Our next speaker is Robin Lunch from the Vermont Green Mountain Board.
Thank you. Okay. Well, I'm glad Josh is gone because now I can tout Vermont and diss Maryland, right? Rebuttal. So thank you very much for having me. I really appreciate the invitation, and I'm excited as always to talk about my home state. I'm going to spend just a few minutes talking about the wrong direction. There we go. One more. Oh, look how fancy I am. So I want to talk to you a little bit about the Green Mountain Care Board to start, and then talk about our history around payment reform and where we are currently. The Green Mountain Care Board was established in 2011, but it inherited a lot of duties that we previously had in statute and that were done by essentially our insurance division, our insurance commissioner. But we were charged with reducing the rate of healthcare cost growth in Vermont while ensuring that we maintain a high-quality, accessible healthcare system. And we work on 3 areas at the high level. One is regulation. We actually do the premium rate setting or the premium review of insurance plans, including our exchange plans. We still in Vermont have a certificate of need statute, so we look at capital expenditures for any healthcare facility, including like transfers and new establishment of entities. And we have a hospital budget process, which I can talk to you a little bit about. It's very different than Maryland's, with kind of the same goals in mind. We've had that in place actually since the 1980s in various forms, so it's something we've been working on for a while. And this summer we're starting a new process where we are regulating accountable care organizations, and our new payment reform model is really built on the chassis of accountable care organizations, so I'll talk in more depth about those entities in a moment. We also have an innovation part of our charge, where we are really the entity within state government that leads on payment reform in the healthcare sector, and we also house the state's all-payer claims database, so we have that in our shop. And lastly, we were instrumental in negotiating Vermont's new accountable care organization all-payer model agreement with CMMI. So we have 5 board members. I won't go through all the details here, but basically 5 board members, 6-year terms. When the board was established, the terms were staggered. So that's why the dates are a little funny, because people had to roll off sooner in order to eventually get to a staggered set of terms. We have 28 staff positions across all areas of work, which for Vermont is a pretty medium-sized state government entity, but I think for this work is, compared to other states, is pretty small. I won't go through our budget, but our budget's just under $10 million, and this just gives you a sense of the breakdown. So the board, as I said, took on responsibility for payment reform in 2011. At that time, Vermont had previously implemented a patient-centered medical home program called the Blueprint for Health. That was implemented under our former Governor Douglas, and he really developed that program over the last really decade. It's currently statewide, And we have pretty much reached saturation with our primary care practices, and as many as are willing to participate and get NCQA certified have done so and are participating as part of the blueprint. The blueprint comes with both a payment to the medical home for being a medical home and taking on those responsibilities, but also there is a separate payment which goes through to each community to create what we call a community health team. And the community health team, it varies a little bit from region to region, depending on that region's preferences and needs. But it typically includes mental health professionals, nutritionists, social workers, really the folks that the primary care office needs to provide wraparound services so that all of those responsibilities are not left to the doctor's office and the doctor's office staff. In many places, the community health team members are co-located different days of the week with different practices, and they really try to provide that support to patients in as seamless a way as possible, so you don't get dropped during the referral process and that kind of thing. That is done as an all-payer model, so we have Medicare participation, which was originally done through a demonstration waiver and now has moved into our new all-payer model. We have commercial participation from our 3 largest commercial insurers. We have Medicaid participation, and that originally was voluntary, and then at some point in the mid-2000s became a required participation for all major insurers in our state. So that really was our foundation, and I think part of what we did in that foundation was not only try to tweak the payment model to include these monthly PM payments to the medical home and to the health teams, but also we tried to ensure that practices had facilitation and assistance when they became NCQA certified to really change the operations on the ground. And so that is also a highlight that we don't necessarily talk a lot about when we talk about the blueprint, but I'll come back to it because it's what we learned in our SIM grant is that this is actually a very key, really key part of the model. So next, our next sort of foray into payment reform were shared savings programs for accountable care organizations. And accountable care organizations, just to level set in case folks don't know, are organizations made up of providers that have as their goal to coordinate care and work together across different provider entities in order to create more integration in the healthcare system. At least that's their goal in Vermont. So we had shared savings programs across all payers, Medicare, Blue Cross Blue Shield, which is our largest commercial insurer, and Medicaid. And 2 of those shared savings programs are still going on. What we found with shared savings is we don't think that it really changed the financial incentives sufficiently in order to have really reduced costs. We have 2 ACOs in Vermont. One of them did get Medicaid shared savings in 1 year. What we've seen is a good amount of quality improvement on the quality metrics, but we really haven't seen cost savings. So from at least our experience in Vermont, we're not seeing that type of financial model, which is still largely fee-for-service and experience from the provider's perspective, has really made a big difference. So when we sort of saw that handwriting on the wall, we moved to our next idea, which was to move to a more aggressive accountable care organization payment model, which we call the Next Generation ACO program after the Medicare Next Generation program. So the payment model that we're moving to now is called an all-inclusive population-based payment. What that means is that it's similar to a global budget in that you look at the population of people that you expect to be in the ACO based on which providers are going to be in the ACO. You look at the historic spending, so you can take things into consideration like age and severity of illness to come up with that payment. And then the participating hospitals get a monthly per member per month payment for a set group of people, and that they basically get this prospective payment similar to what Josh was talking about in terms of the global budget. In our particular Medicaid model, which is currently operational, it started in January of 2017, the other providers are still getting fee-for-service. So it's not 100% global budget for all providers that are part of the ACO. We actually let our ACO design how they wanted to start the payment model to begin with, and started with local budgets for hospitals, I think for a lot of the same reasons that Josh talked about before. Now, the other thing we learned from our SIM grant, which is how we funded our shared savings program, was that provider readiness is really a key part of payment and delivery system reform. And by provider readiness, I mean, so if you are a hospital or you are a doctor's office and you are going to get paid differently, you have to have the capacity to actually make changes in how you do your day-to-day business. There needs to be operational change for the payment reform to actually make a difference. And so we've built into both our ACO program and our Blueprint for Health still has this component, some practice facilitators and other people who are available and can help folks make those operational changes. At least in Vermont, we have 14 nonprofit hospitals. We have about half of them are critical access hospitals. They're pretty small in terms of their administrative staff. They don't have a big quality unit. They don't have a lot of people to do that kind of transformational operational change. So that's something that I always suggest people think about how to really work together on, because it is an important component to actually make the change happen on the ground between the doctor and the patient. So turning now to our all-payer ACO model agreement with CMMI. What we as a state agreed to do with CMMI was to measure across the state financial trends and quality measures to see if we, as we move from volume-driven fee-for-service to value-based prospective payment models for ACOs, could we maintain an all-payer target, a financial target of 3.5% growth. So when you look at Vermont's per capita spending across all our payers, we're actually a fairly low-cost state, but we've been high growth. So across Medicaid, Medicare, and commercial, our per capita amounts are less than the national average, but our growth is above the national average. So what we were really targeting to do was, let's keep our rate of growth more in line with the economy. And so we negotiated a 3.5% target and a Medicare growth target that would be between 0.1 and 0.2% of national projections. And that is a component coming in below the Medicare national projections is a legal requirement of getting this type of agreement from CMMI. So they really can't agree to have Medicare spending grow above national average in terms of the legal component of it. So we were able to negotiate, because for us this is a big lift, right? Because we're already growing faster, so we have to not only get to the national average, we have to get a little bit below. So it also requires alignment in the ACO program across Medicare, Medicaid, and commercial payers. We did a lot of that work with shared savings around particularly quality measures. So we actually have, we've really striven to align quality measures across payers, because we heard from providers, all these different quality measures are driving us crazy. We have to do this for this group and this for that group and these others for this other group. So we worked really hard on finding that alignment, involving stakeholders, and we're happy to talk about the details of that. If you get there and you want to talk more about it, we can have our quality person talk with you, because she's really our expert. And then we also agreed to really focus on improving the health of Vermonters in 3 areas. Now, Vermont is often cited as the healthiest state or the second healthiest state. So we have a lot of good population health metrics on our side, but we do have issues with access to primary care. It's very tough to get a primary care doc if you're new to the state or you don't have a doc and you're looking for one, or you're retired. So we're looking for strategies to do that. We, like everyone else, are struggling with the opiate crisis, and so we wanted to reduce deaths from suicide and drug overdose, because those are 2 of the primary population health drivers in Vermont, and also reduce prevalence and morbidity of chronic disease. So we have, again, statewide measures that we will be judging. And then what we'll need to do is we'll take this statewide framework and then we will apply it through an ACO program to see if the ACO program can help us as a state achieve this. The Green Mountain Care Board is really the regulator and has the regulatory tools in order to achieve those financial targets and quality targets. And this is just a list of various things that we will be doing as part of the agreement, including certifying ACOs. For the first time this summer, we're reviewing ACO budgets. So we just got them on Friday. So we're diving into that. And our job there will be to approve a budget amount for the ACO and determine, how much is admin, how much is going directly to patient care if they're receiving the per capita payments, and reviewing the per capita payments to make sure that they are in the right ballpark but aren't necessarily going to grow too fast. And one unique feature of our agreement with CMMI is, like Maryland, Medicare has agreed to allow Vermont a very small regulatory piece of the Medicare program for ACOs, which is we will set the growth rate on the ACO payment for Medicare year over year. So we will really be able to use that as a tool to align the growth across our payers. So I'll just close with this slide, which I think really just gives you a snapshot of how we've built a regulatory process in order to move forward with this kind of payment and delivery system reform. And I think you don't necessarily need all of these levers to achieve it. This just is really how we've approached it, and I'm happy to talk more about that in response to questions if that's of interest. So I think with that, I'm probably close to out of time. So.
What we'll do is we'll save our questions to the very end. We hear with speakers. Questions from our start, so you can see how to leave it quickly. But please take note of your questions, and for those listening on Facebook, please note your questions. We'll be taking questions in a few moments. Our next speaker from Massachusetts, David.
Great. Well, good afternoon, everyone. It is really exciting to be here today, and I'm just so thrilled to be able to join into this conversation. Thank yous all the way around. Matt, Tom, Dr. Walker, for hosting this really incredible event, and for everyone for coming out here. I'm just really excited about the leadership that Delaware is showing and engaging in these big conversations. And I really want to echo both of my previous speakers in saying that we're here to help. And we truly are passionate about healthcare and healthcare policy, improving our healthcare systems for the benefit of our residents. And I think we are all true believers that states as laboratories for driving these improvements is really the best way to do this. And so we want to be able to provide any type of information, data, consulting. Please call on us. I'm impressed with the work that has been done here in Delaware and the momentum that you guys have in terms of really thinking about some of these issues. And so I think part of my goal here today is to inspire you to keep that momentum going and keep the urgency going on some of these issues, but also to assure you that it's hard. This is hard work, and you are not alone, and there are many here who are sharing in the difficult challenges that face our healthcare system and how to really move forward on this. So keep it up, but know that you're not alone. Before I talk a little bit about what's going on in Massachusetts and some of the ways that we've approached some of these same challenges, I do think it's important to give a little bit of context about Massachusetts, and because it's very different than the previous two speakers. And I think if you think about the different approach that we've taken and the 3 different states have taken, I think you can think about this as kind of a spectrum in terms of regulatory intervention, with rate setting commission and all payer rate setting commission being kind of the most regulatory in terms of the role of government. And then kind of moving across this panel to Massachusetts, where we have more of an approach of working with the healthcare market, working with the private healthcare market, less of a direct intervention regulatory approach, and more of a public-private partnership but with shared and common goals that we track and we hold ourselves accountable to. Some very different things about Massachusetts. We had a rate setting system, like most other states except for Maryland. We deregulated from that rate setting system a long time ago. We're we're all small states, but we're a bigger state here. We have 6.5 million residents in Massachusetts. And in terms of kind of the healthcare system, I think it was mentioned there's about 2 ACOs in Vermont. In Massachusetts, we have about over 25 organizations who call themselves accountable care organizations. And we have one big dominant healthcare system that is founded with 2 very expensive tertiary hospitals, Mass General Hospital and the Brigham and Women's Hospital. Healthcare is the #1 employer in Massachusetts and is heavily connected to our great research, life sciences, and innovation economies as well. So a little bit of a different context. But with Massachusetts, we always have prided ourselves as a state on really pushing the boundaries in terms of healthcare policy. And so have a long history of adopting state-based reforms to try to improve access, quality, and costs. I was working in the state legislature throughout the 2000s and was there when, in 2006, the states, with a broad coalition of employers, consumers, the hospitals, the physicians, and the health insurance companies came together around a plan to ensure access to affordable health insurance for all of our residents. That plan, sometimes referred to as Romney Care, became, in many ways, a model for the Affordable Care Act. But after the passage of our reform in 2006, which was and remains to this day to be highly successful, we have the lowest rate of uninsurance of any state in the country, we really turned our focus to the cost side of this equation because we had made this promise to our residents that they would have access to affordable health insurance. And if the costs in the healthcare system continue to increase at an unsustainable rate, we were very likely to break that promise. And so the public focus after access really shifted towards the cost side. And in 2009, we were a very expensive state in Massachusetts. According to that same data that Dr. Walker showed before from CMS and comparing different states, in 2009, we were the #1 most expensive state on a per capita basis for healthcare expenditures. And of course, #1 in the United States, which, as we all know, the United States is much more expensive than most other developed countries when it comes to healthcare. So we were, as a state, one of the most expensive places in the entire world when it came to healthcare. Some call that a challenge, some call that an opportunity. I'll let you know where we are with some of the updated numbers a little bit later. But I think an important contextual thing here is that as this policy conversation evolved, it really became about our economic competitiveness as a state. This became a jobs issue for Massachusetts because we were so far and more expensive than other states and growing at such a rate that it was crowding out our ability to make investments across the board. You saw the earlier slide about what happens in state government when the spending on healthcare goes up. We have that exact same slide in Massachusetts, except we spend 40% of our budget on healthcare, not 25%. And that limits your ability to make investments in all different types of areas of government. And the same story is true for employers who see their premiums and their share of the premiums going up year over year, and they're making difficult decisions around, do I give wage increases? Do I hire more people, or do I keep providing a good benefit to my employees? And then finally, that crowding out for individuals and families who, during this period are getting very small, if any, wage increases, and seeing all of that money going in the form of higher deductibles, higher premiums, and higher copays. So it's crowding out every single part of our economy's ability to make other investments. And so the reform that we passed, all of this is prelude to the reform we passed in 2012, which is an act improving the quality of healthcare and reducing costs through increased transparency, efficiency, and innovation. What a bill title. And this is our legislative leadership all together signing this big piece of legislation. And here too, again, this was a piece of legislation that the entire stakeholder community came back and said, we're committed to this new effort. The hospitals, the health plans, the consumers, the employers, everyone came together around this new bill, which has at its center this idea of a goal that we can reduce the growth in healthcare spending to a more sustainable rate. And so the law establishes this as a healthcare cost growth benchmark. And this is really the central and organizing principle of the state's efforts, is to be able to meet this healthcare cost growth benchmark, which is set basically through a process that is tied to the growth in the overall state's economy, similar to what was mentioned earlier. And again, that's all about, can we make sure that it's not crowding out our economic growth, but still growing, importantly, still growing. We are not talking about cuts in terms of absolute dollars. And so the rate that we had set that at, and there is a process for updating this, is 3.6% annual growth. Importantly, this is an all-in measurement. This includes Medicaid, it includes commercial health insurance, it includes Medicare. It also includes the out-of-pocket spending that consumers are making. So it includes cost-sharing amounts such as deductibles and co-payments, and the net cost of private health insurance. And the reason you want to have an all-in figure like that is because we know in healthcare, if you're just going to press down in one area, inevitably it's going to pop up someplace else. And we could see a scenario where maybe we were very successful in reducing total healthcare expenditures, but it came on the backs of consumers in the forms of higher co-pays, deductibles, and premiums. And that isn't true healthcare savings to the system. So we really wanted to have kind of this all-in, and what we call a total healthcare expenditures measure that we would track over time. So that's the big idea. That's set in law. And the Health Policy Commission, which I'll talk a little bit about coming up, is an agency that can hold individual systems, both providers and health plans, accountable to that benchmark if they are excessively growing. Underneath that big idea of saying, all right, let's try to meet this healthcare cost growth benchmark, is a number of kind of sub-strategies. And they are all the strategies that we have been talking about and that you have been working on, and that need to work together. So one is transforming the way that care is being delivered in the healthcare system, moving towards a more integrated and coordinated healthcare system that's team-based, has strong primary care, that shares information seamlessly across settings in order to reduce waste and avoidable utilization. Changing the way that we pay for care, obviously a big focus of the conversation here today. If we change those financial incentives, suddenly that rewards providers for doing the right thing, for improving health outcomes, and for making sure that their patients aren't showing up in the most expensive settings and receiving the most expensive care. So here too, we're moving towards more global budgets, which we think really unlock that financial incentive to move in the right direction. Developing a value-based healthcare market. As I mentioned earlier, we do not rate set. We still rely on private negotiations, confidential negotiations between health plans and providers to set commercial rates. And what we know in Massachusetts is that there's a lot of variation in where those commercial rates are set for different providers for the exact same service. And the rate that are being provided are not necessarily related to the quality or value of the care that's being delivered, but more to the market leverage of those institutions to be able to extract higher prices from the insurance companies at the negotiating table. So we need to, if we're going to rely on the market, we need to make the market work better in order to ensure that it's truly delivering value. And then finally, our final strategy here is engaging purchasers. And here, purchasers is really meant to mean both consumers and employers. Give them information about price and quality in new ways, engage them in decisions ranging from what type of health plan they choose to what type of primary care doctor they choose, where they seek their care, but give them information and incentives and have them be a part of this transformation effort as well, and in order to be able to make all of this work for, as it says on the right-hand side, a more transparent and affordable healthcare system in Massachusetts. So a little bit about some other things that this law did. The law set up basically two new state agencies. One agency was an agency that existed before but got a brand new name. This is the Center for Health Information and Analysis, or CHIA. So this was an agency that previously existed. It got a new name and a little bit of an updated mandate. But really, this is our data hub. This is the state's place where we are collecting information, objective information, about the performance of our healthcare system. So we have an all-payer claims database, extremely powerful data source. We collect and report a wide variety of information about the utilization, the price, and the performance of our healthcare system. And CHIA is also in the development of making some of this kind of cost and quality information available to consumers through a searchable website, thinking about kind of shoppable health conditions. And the other state agency that was created is the Health Policy Commission, which I am the executive director of. And this was a brand new agency. I was the first employee of said agency, and so it was both a startup and a government agency, all in the same. And this is really the policy hub. This is the place where we think about and promote the policies that I talked about in those 4 strategies that will allow us to make sure that we hit the benchmark. We set the benchmark through the commission's process. We hold annual hearings where we can call witnesses, hospital CEOs and health plan CEOs to testify under oath around what they are doing to ensure that we meet the benchmark. We do have this ability to require certain entities to take kind of remedial action if they're growing at too fast of a rate, and have some other programs that I'll talk a little bit more in depth about. So this is our kind of who we are, mission, vision. There's a lot of text here, so I'm not going to go through all of this, except to highlight one thing in our mission, which is the second line here, which is the HPC's goal is better health and better care at a lower cost. And it was really important for us to combine these 3 different ideas, and that our mission not just be around lowering costs. We can think about many ways that we could get a lot of spending out of our healthcare system. The best way to cut spending is to cut. But we also know that would be counter to our values as a state. And so it really is around how can we lower costs through improving both the health and the care that's being delivered through our healthcare system. So a little bit about our structure. We are an independent state agency. And so I report to a board, and the board is appointed by the governor, the attorney general, and the state auditor, who are all kind of independently constitutional officers elected. And so each of these different state officials has a number of appointments to the board, and the appointments are in different areas of expertise relevant to the mission of the organization. So you can see we'll have a primary care physician, we'll have someone who is a health economist expert, a behavioral health expert, a consumer advocate, a labor or workforce spot as well. But one important note about how this was designed was that there was very strong language written into the legislation around ensuring that none of these appointees had a financial stake or incentive in our healthcare system. And the reason that that was put in place is that we really wanted to have appointees who were there because of their expertise, not because they were there to represent one specific interest. And so what this allowed us to do is to get out of what we had seen from some other commissions, is that everyone is there to play defense. And everyone is there representing the hospitals, representing the health plans, and we're here just to make sure that nothing bad happens to us. And our role on said board is to just make sure that we can protect the status quo, in some cases, as much as possible. And so what this has allowed, this financial conflict has allowed for people who are really there because of their expertise in understanding how health insurance works, how healthcare delivery system works, but are also interested in moving forward with the overall mission of the organization. We do have, of course, ties to the governor and the administration through ex officio appointments of the Secretary of Health and Human Services, as well as the Secretary of Administration and Finance. And these are all staggered terms such that won't roll over depending on kind of a specific election. Again, attempting to give some stability and political insulation over time for the commission to be able to do its work. This is kind of the strategies that we deploy to drive our mission and to drive the state's ability to meet the benchmark. One is our research and reporting. So we have an amazing staff that has and takes that great data from CHIA and puts out incredible reports, clearly identifying where are those opportunities to get some savings out of the healthcare system, and to make sure that we're publicly putting this information out, and in some cases using that to help the market be able to make progress. We're a convener. We know and have learned that for many organizations, they do not view the government agency as being the best voice in terms of telling them how to transform and change their healthcare delivery system. So what we found is more effective is being a place where we can bring people together. And bring people together and bring the best experts together. So it's not necessarily us, government, we know best, but really a place where we can engage the best minds and the best thinking to identify what some of those solutions can be. We're a partner, so we work directly with provider organizations and health plans through some grant programs and some investment programs, actually seeding money into the healthcare system and working together to meet some of these goals. And then finally, we're a little bit of a watchdog, which is to say we also will identify things that we think are truly areas for potential negative action in the healthcare market or in healthcare spending, and to highlight those organizations that are contributing to excessive cost growth or that are engaging in market activity that is counter to our overall goals. Just so you have a good sense of kind of our footprint, we have about 55 FTEs now as a state agency goes, and our annual operating budget is around $8.5 million, and those costs are annually assessed to hospitals, surgery centers, and health plans, such that we are kind of budget neutral to the state. So these are our big four main responsibilities that align with kind of those strategies I mentioned before. Monitoring system transformation and cost drivers, making investments, promoting a more efficient delivery system, and then finally, where there are changes that are occurring in our healthcare market, how can we ensure that they are happening in the best interests of the consumers and businesses that bear the cost of our healthcare system. So I'll take these quickly in turn, and then I'll sit down and we can engage in more of a conversation. So first of all, how have we done in terms of our effort here? This is all total healthcare expenditures, basically Massachusetts versus the United States. US is the blue line, Massachusetts is the kind of gold-ish line here. And you can see that since 2009, which I said before was our high water mark, we have been about at or below the nation when it comes to total healthcare spending growth. And as you can see, that's a big change from where we were throughout the 2000s, where we're very consistently much higher spending growth than the country. So great that we have been at or below, but also a big change from the previous decade. I mentioned earlier that we were #1 in that 2009 data. Well, the new data just came out, I think last week. So now 2014 data has come up, and great news, we're no longer #1, we're #2. In 2009, I looked this up, Delaware was #5, and now you guys are #3 in terms of that most updated number. So we're #2 and #3. We can figure this out together. But importantly, from 2009 to 2014, when it comes to spending growth, Massachusetts was 46th in the country. The 4th lowest spending growth of all states in the country during that period of time. And Delaware had the 7th highest spending growth during that period of time. So we were able to bring our spending growth down over the last couple of years, and that has allowed for more of a convergence between us and the United States. all of this to say, still a lot of tremendous work to be done, and some significant affordability challenges that remain. This is just on the commercial spending growth, which is something that we look at a lot as well. And here you can see even a more significant divergence between Massachusetts and the United States in terms of commercial spending growth during this period of time. Good news, we are still number 5 most expensive when it comes to commercial health insurance of any state in the country. So I mentioned that we have this 3.6% benchmark. So how have we done in terms of performance against the benchmark? Well, we've measured ourselves over 3 years, and you can see in 2.4% in 2013, 4.2% in 2014, and 4.1% in 2015. So yes, we did exceed the benchmark in the last 2 years of performance, but I always like to do this little average growth rate, 3.57%. Take it to that extra decimal point so you can see that we have been pretty much in line with the benchmark over this period of time. Importantly, there were other contextual things going on. In 2014 and 2015 in particular, we had very high growth in pharmacy expenditures. I think about 13% growth in 2014 and about 8 or 9% growth in 2015. So if pharmaceuticals had grown at, say, the 3.6% benchmark, we would have hit the benchmark in all 3 of those years. So pharmacy is a particular challenge right now. The next thing that we do is we do make investments directly into our healthcare system. We have a grant program. It's specifically for community hospitals. I will put this slide up, but not talk through it too much, other than to say community hospitals provide a lot of value to our healthcare system. We think they're a big part of the solution. They face a lot of very unique challenges and have seen a lot of that routine care in Massachusetts go to our more expensive academic medical centers. And so we've had grant programs in place to try to work with our community hospitals. And many of the things that those grants are doing are exactly the same things that Josh was talking about earlier. We're actually designed a grant program where we're giving money to hospitals to help them reduce their hospital utilization. So reduce readmissions, reduce avoidable ED use, reduce avoidable admissions. And it's a really interesting grant project because when we go and talk to these hospitals and we say, we talk to their chief medical officer or their director for population health, they say, this grant is amazing. It has unlocked our potential to do so much in terms of getting patients out of the hospital, back into the community, and the supports they need in the community so that they're not returning to the hospital. We're able to use community health workers in ways that are just truly dramatic in really bringing the care to where the patients are. And these are really vulnerable, high-cost patients, multiple ED visits in a month, lots of readmissions, huge behavioral health needs, social needs, and we're bringing that care to them. This is an amazing program. And then I talked to the CFO, and the CFO says, yeah, this is all great and good, but I'm losing money because of this program. We're losing revenue because we count on revenue from people showing up in the hospital. And so we in Massachusetts are still in this place of on one hand and on the other hand, there's so many different metaphors that are used in terms of feet in canoes, whatever it may be. It's the fee-for-service world on one hand and the new global budget world and reformed payment world on the other hand. And when the CFO is thinking about heads and beds and I need to get people in there, that's the fee-for-service world. When the population health director is talking about building connections with schools, with law enforcement, to try to provide care outside of that four walls of the hospital, that's the global budget world. We're still stuck in the middle in Massachusetts, but we are driving very hard to try to get to that other side and to make sure that everyone is really in that population health side of the world. The next thing that we do is really on that care delivery side in kind of promoting models that we think will be truly effective in meeting these goals. And so we have two kind of recognition and certification programs that we've established. One is for patient-centered medical homes. That has a specific component to it. We're really focused on behavioral health integration into primary care as a setting of care. And the second is around certifying ACOs. Everyone, I think, probably has a very different idea of what it means to be an accountable care organization. Many people call themselves accountable care organizations, but they're providing care in the exact same way that they were yesterday. And so we now have a standard in Massachusetts where we say, we're going to actually certify you as an ACO and test and understand what are you actually doing differently that is consistent with that more coordinated and value-based healthcare delivery system. Both of these programs are technically voluntary, although I would say in the case of the ACO program, our state's Medicaid program has made that a requirement to participate in their next model of of payment reform. So there is this kind of direct linkage. Also importantly, this is all payer. Both of these programs are all payer certification programs. And I think you've heard from all of us a testament to all payer approaches to this work. And then finally, the last thing that we do, which may not be as directly relevant to Delaware, is that we do know that the way that our healthcare market is organized can have a significant impact on the delivery, the cost, and the access to care. And so we know that consolidations are occurring at an extremely rapid pace across the country in terms of both hospital and physician consolidations. And so we have established through us a new process where organizations that are seeking to merge or consolidate or to create new relationships have to go through a review process by us, which will test and kind of evaluate what the cost, quality, and access impacts of said proposed transaction would be. It's different than a determination of need process, which traditionally just looks at kind of access issues or capital expenditures. This really is around kind of market consolidation. We don't have the ability to deny at the end of the day, but we do bring public transparency to those transactions. And through that, we have found that it has changed market behavior. Even shining a spotlight can change market behavior and asking questions. Why is this in the interest of the public to pursue this new relationship? And we've been holding the providers in our market feet to the fire and holding them accountable to making sure that those promises are actually delivered upon. So with that, I'll conclude my remarks. Again, happy to make connections with you. Really, just if I couldn't say it enough at the beginning, encourage you to keep moving and to keep going on this path and journey that you're on. Maryland, Vermont, and Massachusetts, I get invited to a lot of different panels across the country with the three of us all together. It'd be great to have a fourth at this table, Delaware. I feel like you can do it. And one of my favorite quotes, which is from Franklin Roosevelt, it is common sense to take a method and try it. If it fails, admit it frankly and try another, but above all, try something. Thank you very much.
Okay, well, I believe we only have one microphone, so I'm going to give it to our panelists to share among themselves, and we'll take some questions now. In the back, please speak up.
Great. So the question was, first, in terms of this movement towards patient-centered care, how can we ensure that kind of preventative care is a part of that in many cases where it's not easy to bill for some of those types of services and for work. And the second was around kind of providing grants to institutions to avoid some market consolidation. So I would actually completely agree with you on the first point. Certainly when we think about and talk about patient-centered care, we think about and talk about the team approach. The team that has a primary care provider, that could be a nurse practitioner, that could be a physician, working with the social worker, the dietitian, the pharmacist, all working together to be able to address the needs of those patients. But our system is still in many ways set up that it has to be under these billable codes. And so when we think about expanding and providing more flexibility, that's why we do need to move away from this fee-for-service model. And being able to provide that flexibility and revenue to providers so that they can detach themselves from the hamster wheel of billing and coding and all of these things. That will always continue to be a part of our system. But if we're really going to move from a sickness healthcare system to a healthcare system, we have to figure out different ways of being able to pay for and reimburse and support that type of preventative care. So I completely agree with the sentiment, and I think we still have some work to do on that point. The second was around providing kind of grants on the market side. I think one of the things actually that speaks to both points is that with the grant programs that we've done, in many cases we are actually using those grants to pay for services that would otherwise not be reimbursable, that there are no codes for. There isn't a great code for sending a community health worker to the homeless shelter, underneath a train stop to say, hey, did you take your medication today? And so really, we're trying to test some of these different flexible ways of doing this. I think the overall market consolidation, there are so many pressures and drivers pushing that. I don't know that state dollars and grants can prevent that. I think it's more about kind of steering it into a place where, as those transactions occur, that they're going to be held accountable to delivering on the quality improvements and access improvements that many of them are based on.
I would just add, for your first question related to the referrals, the way that we've structured our community health team payments is to have each insurer provide a per person amount to a regional entity so that there is no code that needs to be billed. It basically creates a pot of money for each region to create these community health teams to provide those wraparound services. So that could be potentially a model for avoiding the billing issue. As the regional entities. In some regions it's the hospitals, in other regions it's an FQHC, but basically the job of the regional entity is to collect the money and then hire the staff, but the staff actually work for the entire region, not the specific entity. So there's different models depending on the county or the region. It's true. I think that it does present some issues if you have robust private practitioners in that specific area, because this model doesn't solve that problem.
David, I'm glad you brought up the issue about pharmaceutical costs, because who regulates that? And the problem is we have incredibly expensive drugs. I work on the behavioral health side, and health plans cover certain ones that don't, and it requires the physician to go through multiple steps to get certain drugs prescribed, you have to fail on certain drugs. And even in our Department of Corrections, we have a drug that will cure hepatitis C, but the cost of that is $125,000. So, how do we deal with that in this overall sort of managing cost problem?
It's a great question. So, a couple of things. One, I mentioned there was a high increase of pharmaceutical spending during that period of time. Some of that being driven by incredible life-altering innovations. The hepatitis C is a cure, and that provides over the long term tremendous value. Now, that's over the long term. At the beginning, it's a very expensive drug that causes a lot of challenges in terms of our ability to afford that. Here's what we know. We know that the pipeline of innovation that's coming down is filled with new therapies, technologies, devices, and therapeutics that will all be very, very expensive. And so this is a huge challenge for states and for these efforts, because so much of that is regulated and kind of dealt with at the federal level. And the role for states in some of these areas, especially in the pharmaceutical, is an open question what levers we actually have. That being said, some states are doing some interesting things. Vermont has, well, I'll let you speak about Vermont. Do you know the transparency stuff? Yeah, I'll let her speak about that. New York, Nevada, are all working in this area of at least pushing on the transparency of what is happening with prices and utilization. The pharmaceutical part of this world is opaque. We have discounts and rebates that are calculated sometimes after the fact. But I think the big drive on pharmaceuticals, and the one area that I am optimistic in, is moving towards payment structures that are based on what is the value that is being provided by these new therapies. And there are new contracts that are being put in place where health insurance companies and the pharmaceutical manufacturer will actually have a kind of a risk contract, where if it doesn't deliver that clinical value that it was supposed to, that the insurance company can receive kind of additional rebates or additional discounts. So that it really is, again, tied, just as we're doing with everything else, to what is the value that is being provided to the healthcare system or to patients of these things. That being said, the price that is often set for pharmaceuticals is based on what the market can bear, not on value. So I do think we need to kind of continue to shift and push the manufacturers to really think about setting prices based on the value of the services that they're providing. But again, from a state perspective, it's a difficult one for all of us.
In Vermont, we tried to shine some light around the price transparency issue on pharmaceuticals for our Medicaid program in particular by passing a bill that requires the Vermont Care Board to work with our Medicaid agency to determine which top 20, let's say, drugs had the highest price increase for Medicaid patients. So it specifically looks to which drugs are going up within the last year. So we just published that for the first time last summer. We'll be doing it again this summer. And we hope that transparency at least shines some light.
Yes, there's. This is a question from Facebook, and the person requests to remain anonymous. But the question is, how do you see local community pharmacies playing a role in the new models, and do you see these organizations falling to the wayside and not being utilized?
So our accountable care organization model relies on the provider community to organize themselves in terms of how to best deliver patient care. And certainly community pharmacies are an important part of that model in our state, at least. We have, I think, probably quite a few community pharmacies compared to some other states, and we have really, as a state, focused on ensuring that we maintain that business model. So not so much for the accountable care organization model, but the state has passed legislation that would equalize payments to community pharmacies and mail-order pharmacies, for example. So at least with our models, we've on other areas looked to ensure the viability of those pharmacies. I think for many Vermonters, they're often the only choice. So they are really important, and we think that our accountable care organization model will not be to the detriment of those communities, because I think that they will need to stay in place.
I would just add, I think from our experience with the grant programs that we've run, which again, really focused on complex patients and reducing hospital utilization, we found that both pharmacists as part of the care management team, but also connection with local pharmacies to be incredibly effective intervention in terms of ensuring that these patients aren't bouncing back into these high-cost settings. Really, from a medication adherence standpoint, I think there are tremendous opportunities to engage different aspects of that local community with the healthcare system, all working together to say, what do these patients need? And so I see there is a bright opportunity for local pharmacists to be a part of that team in thinking about reducing unnecessary utilization.
Yeah, my question was about primary care, patient-centered medical home. All three states that were presented talk about
to our model. And so you may recall from my slides that one of our 3 population health goals that we are monitoring will be increased access to primary care. And we also act as a convener. So when we convene folks together to talk about our accountable care program, there was a big emphasis on how do you put more money in primary care and how can you work through that funding mechanism as an ACO. So we had a lot of, we did it by convening people together, really laying the problem out that, we need more access to primary care, we need more money going to primary care, and ask the provider community to work on how to strengthen that relationship, and then the funding changes would flow through the ACO. And then we as a board will be monitoring how that spending changes over time. We have metrics for looking at access to primary care, and so our role as a regulatory entity is really at the top, sort of like what you were saying in terms of shining a light and talking about what we're seeing in terms of trends. So we've taken a little bit of a hands-off approach there, but certainly our Medicaid program also is very interested in that and thinking about ways that they can work on that.
So for Massachusetts, again, a less regulatory model here. One, we do have a recognition program for kind of, as I mentioned, primary care practices that are especially both recognized as a patient-centered medical home through NCQA, but have taken some additional steps in behavioral health integration. I think as a matter of policy, we just ultimately believe that's a better way of delivering care, even if some of the kind of extensive national academic literature is a little mixed on, is it a good way to reduce kind of total spending? That, in addition to that, as I said, we also kind of have it going from the top down, which is the ACO side of this. And so most of our primary care practices are now affiliated with one of the big major systems. In Massachusetts, we truly do not have any kind of totally independent, non-affiliated primary care practices left. They are at least affiliated with many of the big systems. And so there the question is, what is the ACO doing, which many times includes hospitals and other organizations, to both translate dollars down to the primary care level and ensuring that they're being supported. And so we have, as part of our certification program, asking the ACOs, how much of kind of the total global budget are you translating down to the primary care practices? When you as an ACO come in under budget, who gets that bonus? Does the hospital get the bonus, or do the primary care docs get the bonus? We didn't start this with saying there's one right way to do this, but we want to at least have an understanding of what the landscape is, and over time, hopefully have some evidence to say, well, what is the right way to do this, and maybe we should be pushing more towards the primary care side in more of a mandated or regulatory way.
You sparked something when you talked about the shared savings or the bonuses. Part of what we're, for the first time, as I said, looking at accountable care organization budgets. So part of what we will be looking for is what is their model for ensuring that we're increasing access for primary care. When they do have bonuses or shared savings to share, what is the percentage that's going towards primary care to other providers? And because we are reviewing the budgets, we have that regulatory lever to influence it.
Well, I'm going to take this moment as the moderator to ask my own question. As you heard Dr. Walker mention, in Delaware, we're on the cusp of we're at the crossroads. And we've talked about payment reform for quite a while. And David, you made reference to the fact that everybody coming to the room, they go on defense right away. Certainly that's been the case for us in our discussions. So, granted that we all buy into the triple A, and that's our motivator, what made your state take the lead beyond the triple A? What really drove the change and made people say, okay, we got to stop talking and do something?
So, I think, as I mentioned at the top, I think we couldn't continue on the path we were on. And I think we realized and understood that. And so putting a stake in the ground with the benchmark was incredibly powerful for us to say, we all agree that here is a very tangible and measurable goal that we're all going to get behind. And now we're all going to work together to figure out how we make that a reality. And I think that having that stake in the ground, having something that you can measure and see really provided that ability for us to work together with all the different parts of the healthcare system, not as big bad government, but something where we're really truly all in this together to meet that goal. And I would say leadership matters. And I think leadership from the state, leadership from the health systems, and leadership from the health plans. The leadership has to say we are a part of this community, and that the health and well-being of this community depend on our ability to make some progress in these areas. And so engaging that leadership is also critically important. And then finally, I would say on the complete opposite end of leadership is connecting this to people, and connecting it to real life stories of people who have seen their healthcare system fail them because of the complexity involved, because of the fragmentation, and who have seen that they can no longer afford the great care that they need. So I think a couple of different levers from the Massachusetts experience.
And I think our levers were similar. I completely agree. Leadership matters, and stories really highlight where the system is broken in your particular area. We also, although we, I think, spend less than either of you guys on as a percentage of our state budget on healthcare, for us it is still unsustainable at the state budget level, and certainly in our premiums, private insurance premiums, we know that the cost increases are really too much for what families in Vermont can afford. I think when we were looking at the data over the past decade, pretty much any wage inflation went into healthcare. So wages have been flat in our state for the past decade. So that was really an economic imperative behind what drove the change. I would say somewhat facetiously that, although a little bit seriously as well, we also, our previous governor, Governor Shumlin, wanted to create a single payer system in our state, and I think that also created some anxiety in the provider community that may have driven folks to think more aggressively, but quite frankly, I think they would have been there anyway, even without that push at the gubernatorial level, because we have some great leadership in our state among our healthcare providers and our insurers in terms of thinking about how to really move forward. Lastly, I would say there is a national push from CMMI and CMS that I think all states should be thinking about, and that's MACRA and MIPS. I don't know if people know about MACRA and MIPS, but basically, yay, I see a hand in the back, and I won't get the acronym right, so I won't even try. But basically, Medicare is saying that they're moving their fee-for-service towards value-based payment, and providers could see either up to a 9% bonus or a 9% ding in their fee-for-service, depending on how their quality measures up against national averages. And so I think for us, that also, for every state, providers have to be thinking about, okay, fee-for-service is moving towards this kind of quality measurement. Am I ready for that? How's it going to impact me? And is there a more palatable alternative that might actually help me change my practice in an area that really is patient-centered? So I think that's a national trend that will help all states realize that we need to really be creative, thinking about the best ways to move forward.
Okay, now for the pressure, we have one last question. Who wants to take a chance there? You're going to have to get it done.
Okay. David, you mentioned the ACO certification, and you each touched on it that there are some requirements. What has been the feedback from your provider community with regard to that certification? Is it an evergreen certification, so is there a process of recertifying after a certain period of time to ensure that they still have the infrastructure needed? And does the certification allow them or actually give them mandate that they have more communication down to the practice level in your ACO certifications?
So I'll speak about Massachusetts and then turn it over to Vermont. So our program, I think the feedback that we received from our provider systems was don't set the bar too high. We are still learning and still developing these types of systems. And so if you're going to, as a requirement of certification, include a long laundry list of things, that we are unlikely to be able to meet, we're not going to be able to be a part of this program. We won't be on this journey with you. So we made a strategic decision to set our bar a little bit lower in terms of kind of allowing more organizations to be a part of the, to be a part of the initial certification, but it does renew every 2 years. And so we think of this as really kind of a long-term journey, where we're getting some people into the program right away. And as we learn more about what are the successful ways that ACOs are able to do this, pushing that bar up more and more, so that it becomes something that people can be a part of that path, but that we're actually pressing towards something meaningful at the same time. So in the first year, we have some minimal requirements, things like, do you have a patient and a consumer on your governing board? Do you have ways of communicating across different sites of care between post-acute and so on? Do you take value-based payment as part of your payment model? And then we also included a whole bunch of questions that they are required to give us information on, but we're not judging them on. And so we're asking them, how do you pay for your primary care? How are you integrating end-of-life care into your ACO? How are you addressing the social needs of your patients? And they may have a whole range about how they're actually doing that, or maybe they're not actually doing that, but we'll have this incredible view to know, here's where everyone is. And now please start to push them to say, next time around, we're not just asking what you're doing on end-of-life. We're going to say, you have to be showing us that you're doing X on end-of-life.
Yeah, and in Vermont, similarly, we haven't started our ACO certification. We have a rule that's currently up for public comment, and we will be doing the certification for the first time early in 2019. Okay. So our rule is currently in process right now. But we do have quite an exhaustive laundry list in our statute of different components to look at as part of the certification. But we have tried to craft the rule in such a way that we allow for innovation and change over time as well. So our certification would be every 3 years, but because we also have an ACO budget process on an annual basis that looks not just at the financial components, but also the program itself and how they're addressing social determinants of health and how they're working towards the population health measures that I mentioned earlier, we will get more qualitative data on a year-to-year basis through submission of the budget and supporting materials in the hearing process. So we kind of have a mix and match. So we're thinking of the certification more along the lines of sort of a minimal licensing standard, and we'll allow them to deem certain things. But that is because we have this annual look across the board about their program.
Well, first, let's thank our panelists. What we'll do now is while we're checking batteries and microphones, we'll also take a 10-minute break, and let's be back here promptly at 2:55. Get some water refreshments, and we'll have our next panel in 10 minutes.
Hi. This afternoon session is going to focus on the national and research perspective, and without even planning it, our last question and our last response fed right into this when we started hearing those teaser acronyms of MACRA and MIPS and things that are going on at the federal level. So thank you to our last panel for doing that. We have two great speakers with us today, and in order to allow ourselves enough time for questions, I am not going to read their bios because they're all in the brochure that you got. I'll just give you a little quick introduction based on the order that they are going to speak in, and then we will have them do their presentations, and then much like the last panel, at the end, we'll leave plenty of time for you to get your questions answered. So first we have Dr. Peter Hussey with us. He's the Program Director for Health Services Delivery System RAND Corporation. And second, we will have Dr. Robert Saunders, who's the Research Director, Payment and Delivery Reform for Duke Margolis Center for Health Policy. Without further ado, I will turn it over to Dr. Hussey.
Thank you. It's a real pleasure to be here to talk about the national landscape. It turns out there are some things happening at the national level in policy, so we have some things to talk about. It's a real important time for you. It's a real honor to be here while you're at this crossroads. And what I'd like to do is really zoom back, take stock of some national trends and what it might mean for what you're all trying to accomplish here in Delaware. I work for RAND. We're a nonprofit, nonpartisan research organization that is based in California. And we do a lot of work on payment reform, among other areas. And our mission is really to help improve policy and practice through research and analysis. So I hope that we're a resource for you. Everything that we do is available to all of you. And feel free to reach out to me to provide as much support as we can to what you're trying to accomplish here in Delaware. It's very important. Grab the clicker here. Okay, so let's take some steps back and think about where we are as a country. So first, where are we in terms of payment reform nationally? At the national level, the term of art is alternative payment models. That's alternative to the status quo when it comes to healthcare payment. Status quo is predominantly fee-for-service, which is payment for volume. And the alternatives take a number of different forms, but what they share is payment linked to value. And value is some combination of cost and quality. So where are we in terms of how these models are taking off? Well, it's a little bit difficult to count, but by some estimates, in the commercial sector, we're at about 22% of payments that are in some way linked to value. That's a little bit higher in the Medicare program. Secretary of Health and Human Services actually set targets for where they'd like to be in Medicare, and they're quite ambitious. And so far, they're on track to hit those targets. It's a little bit higher in Medicare Advantage and a little bit lower in the Medicaid program. So it's been increasing over time, certainly. It's has a foothold, I would say, but still not predominant. Still the bulk of the payments here are going through fee-for-service. The CMS has really been, I think, providing maybe the engine behind a lot of this. They've been out in front in the Affordable Care Act, created the Center for Medicare and Medicaid Innovation, and they're taking an approach that's really let 1,000 flowers bloom. So there's just a ton of experimentation happening through there. Some of that's happening through states, some of it's happening through CMS, and some of it's also multi-payer. They're testing 39 different models right now, and the Secretary has the authority to scale those models if they're shown to have favorable impacts in terms of cost and quality. And so far, they've identified 5 of those models that in some form have favorable impacts on cost and quality. 2 of those have been authorized. The first 2 on this list, the Pioneer ACOs and Diabetes Prevention Program. So 2 of those have been authorized for scaling nationwide. So lots of activity at the national level, lots of models out there being tested. That said, I think if you dig a little bit under the hood here, maybe a little bit less of really actual dollars tied to value. So while maybe 30% of payment programs have some link to value, it could be as little as 1 or 2 quality measures. Typically it's more than that. But if you actually look at dollars that are changing hands, how many of those are actually linked to value instead of for doing a service, it's probably a little bit less. I think also it's important to note that there's some important things happening behind the scenes. So these models get a lot of the attention. The medical homes, the ACOs, et cetera, they have confusing names that nobody really likes or understands. They have lots of complex terms. There's some other things that are happening that I put in the category boring but important. So there's really kind of arcane rules that govern some of these payments. So in this chart, which is probably hard for you to see in the room, this is an analysis we did of Medicare payments for inpatient care. And as you all know, that in Medicare, inpatient care is paid through DRGs, but things like the outlier adjustments, so when you have an particularly expensive patient, you get an extra payment for that as a hospital, that changes over time. And so you've seen some shifts here. That peak around 2002, that's due to the outlier, and then decreasing over time when they put in MSDRGs, decreased even further because that's more tightly linked to actual services. What you see here at the end is actually the hospital readmissions reduction program. that increased the financial risk that hospitals face quite a bit, actually. And those are things that have been talked about a little bit, but maybe not so much, but are a really important part as you think about how you move forward here in Delaware. Keep track of some of the boring but important things, as well as some of the things that get more headlines. Okay, so as our last panel alluded to, there's been some changes nationally. I think that could really change the landscape here in Delaware and across the country. Maybe lost in some of the divisive political fights we've been having was that there was an overwhelmingly bipartisan piece of legislation affecting healthcare, and that was MACRA. It happened a few years ago. And that fundamentally changed the way that physicians are paid under Medicare, and Medicare is by far the largest payer for physician services. And this, I think, could really change a lot of the landscape. So for those of you who aren't familiar with this, this replaced the previous model, which was called the sustainable growth rate. And what that model was doing was calling year after year for really big, over 20% cuts in the price per service for physician services under Medicare. And what Congress did in response to that was override it every year. They did that 17 times, until finally they came up with MACRA, which did away with that formula and replaced it with something else that's probably equally or more complex, but now it starts to have more of that value orientation. So under MACRA, there's two tracks for physician payment. One is called the merit-based incentive payment system, the other is called the alternative payment plan track. And under MIPS, that's the default option for physician practices. That is your basic fee-for-service payment, but it has a bonus, the penalty payment, that increases up to plus or minus 9% over time. And that bonus or penalty is based on performance in 4 domains that includes quality, cost, use of electronic health records, and clinical practice improvement. And in that way, it consolidates previous programs that Medicare had been developing for measuring physician performance. So there's going to be a lot of attention for physician practices on how they can report these, if they're going to be earning a bonus or a penalty. But the other thing it does is create the second track, the Apm Track. So if physicians meet certain benchmarks for the number of their patients or revenue that are participating in qualifying models here, then they will qualify for this track. Why is that important? Well, they get bonuses, participation bonuses, which I'll show in a second, as well as higher payment rate increases over time. In exchange, they're taking on more financial risk and also willing for quality, so value. And there are a subset of alternative payment models that can qualify you for this track. It's not all 39 models that I named on the last slide. It's a subset of those that are named by the Secretary of Health and Human Services. One thing that you want to keep in mind here in Delaware, there will be an incentive for physicians to get on this track. Anything you can do in your reform here to sync up with that and get them able to qualify will likely be synergistic with what they're experiencing at the federal level. So let me show that in a little bit more detail with some data here. This is showing physician prices over time, a projection of physician prices over time. This is based on an analysis we did and published in the Journal of Health Affairs. On the y-axis is relative to what prices were in 2015. And there's 3 lines. One is what we think would have happened if MACRA had never come around. That's the pre-MACRA baseline. So that is, we assume Congress would have kept on doing what they were doing, which was overriding the SGR and having small but positive increases in the amount physicians get. The red line is the Apm track, and the bottom one is the MIPS track, which is orange. And what you can see there is under the MIPS track, it's small increases up till 2019. For 2020 through 2025, it's a 0% increase in price per service. And after that, there's a little kink there in 2026. That's the expiration of the sequester. And then after that, it's a small positive rate of increase in nominal payment rates under the MIPS track. And you can see the red line, you'd rather be on the red line. Okay, so that's a 5% bonus payment for the years 2019 through 2024. That then expires, but afterwards you have a slightly higher rate of increase. You'll notice that both of those are underneath what we would have expected to see under if MACRA had never happened. And for comparison, this is a projection of practice cost inflation. This is what Medicare uses to measure practice cost inflation. So what's kind of obvious from that is all those lines are beneath the rate of inflation. So if you're a physician in practice right now, it's going to be a forecast from the federal government, tight environment in terms of revenues. And so the flip side of that is, to make things work, you're going to have to find other ways of making money. It's going to be, I don't run practice, but if I was looking at this, I'd be thinking about cost reduction and potentially branching out to other types of expanding what you're able to do.
Can I ask, is this all physicians, primary care, or does it include primary care and specialists?
Yes, it's all. Yes. That's right. Now, on the APM track, that is, there's a lot of different things that could be in that track. So right now, there's a certain number of models that are named. There could be more over time. What those look like, that'll have a big impact ultimately on what it does. So we try to project that out. You can see there's a pretty sizable difference. When we say prospectiveness, that's our measure of the financial risk in the model. And under the high prospectiveness, that would be like if everybody was in a next generation ACO. Low prospectiveness would be if like everybody's in a medical home. There's a pretty big difference between those. So the design of this will really matter. This is showing Medicare revenues. There's also an effect on hospitals. So I'm talking about physicians, not just because physicians are an important part of the healthcare system, but because they also control a lot of resources that flow to other parts of the system. We heard about that with Josh, talking about, well, we need to get the physicians on board ultimately with what the hospital wants to do. So here, what's important to keep in mind is if physicians are incentivized to keep patients out of the hospital, that has an important effect on hospital revenue. It turns out hospital revenues are a lot higher than physician revenues, so a small change here can actually totally outweigh what happens on the physician payment side. The flip side of this, of course, is that it's good news from the Medicare budget perspective. And the Medicare budget, you all know, is they're facing bankruptcy in the Hospital Insurance Trust Fund within 10 years, give or take. And the federal budget is running a large deficit. So that's the general environment. Sorry to be, it's a little stark, but those are that's the environment we're operating under. So as a backdrop, again, anything you can do to help physicians along, they're going to be facing a challenging and changing environment of practice. So let me turn now and talk a little bit about what we know. I don't have time to go through a lot of the research on these different models. Just to point out that we're still learning. There are many evaluations going out there of all the things that are happening. And I'll just characterize it at a very high level. I don't think we've identified the silver bullet yet. There's no slam dunk out there that I can point you to, unfortunately. But there are lots of glimmers of hope and positive signs that we're seeing in some of the models. These are some of the most common types of models. So bundled payment is the idea of paying for an episode of care around something like a hip fracture. This is something that has a lot of conceptual appeal. So for providers, they know sort of when a hip fracture starts and care for that and when it ends, more or less, and are sort of comfortable with a care pathway there and how they could re-engineer care around that. Practically, it's a little bit more difficult than that, defining what the episode is. These models, as a result, I think we're a little bit slower than expected to get off the ground. One of the biggest ones that Medicare is doing is actually mandatory in certain geographic areas so they can evaluate what happens. I'm not sure if Delaware is one of the areas where that is mandatory. That's something that Secretary Price has objected, who's an orthopedic surgeon, has objected to pretty strenuously, so I expect that might change. That all said, there's been some positive signs from the Medicare bundle payment programs, particularly around the area of patients discharged to home instead of to institutional post-acute care. And there's some evidence of orthopedic surgeons doing things like more pre-treatment, pre-surgical treatment, what we call prehab of the patients, in order to have them have more successful surgery, more likely to be able to discharge to home, which is in most people's preference and also a lot less expensive. Medical homes, there's a lot of evidence around the importance of primary care. There's a lot of evidence that this is important as a foundation for the health system. Not a lot of evidence that medical homes themselves will save money. That might not be the right standard for what you want to expect from a medical home, but it is an important foundation, I think, for these other delivery efforts. And there's been some signs, so there's lots of variations in how this is implemented. I think we're still trying to sort out what's the secret sauce that can make this work. But we do know the transformation for primary care practices is pretty difficult, and I'm assuming that's something that is underway in many parts of the country, so there's a lot to learn there. And then accountable care organizations also, I'd say some promising early signs, but no huge effects that we've seen in Medicare programs, for example. We've seen some modest quality improvements and modest cost reductions in some of those programs. Rob's group has done some work there. You might be able to fill in if you have questions about that. Okay, so another way of thinking about the impact is to go out on the ground and find out how this is changing practice. And we've done that in physician practices and with other stakeholders across the system. So I want to talk about some of those findings. So this is based on a study that a colleague of mine at Rand, Mark Friedberg, led. We looked at different geographic areas of the country and went into physician practices to try to find out what's happening in response to these alternative payment models. So when you ask physicians about how face-to-face care with patients has changed, generally they say, hasn't changed much. When I'm in the room, I'm still doing the same things I was doing before, give or take. What has changed is the stuff outside the room. So we have invested in care coordinators. We have invested in electronic health records. We're doing new things that we had in the electronic health record. You know, we're now looking at data in a way that we never did before, and that's really important. At the same time, there's this increasing trend of volume expectations for the amount that physicians are trying to do. There is more team-based care that frees up the physicians to focus on maybe some of the more top of the license type of things. So, you know, some of the routine things can be delegated, freeing them up to work with the most complex patients and the most complex problems. The only issue with that is it's taxing. So, you know, keep in mind, as a backdrop here, we've got a problem with, I think, physician burnout that's increasing across the system. One of the biggest contributors to that is actually the non-clinical work. So, along with these payment models, they can come with requirements for lots of reporting requirements, et cetera. There's a good rationale behind that, but it's really easy to do that in a way that adds a lot of burden that people don't see the value in terms of clinical care. And that, we heard resoundingly, is really driving discontent and undermine some of the goals that I think everybody shares with these payment models. Another thing we heard was that physicians earning bonuses on some of the payments don't really understand why a lot of the time, so that's a little bit of a problem if you're trying to get them on board. So I'll talk about that a little bit more in the future. The other thing to recognize, I think this point was made on the previous panel, is that there's a real continuum of practices. So the early adopters are out there, and they say, we see this train coming into the station, we want to get on board. Okay, we know we're not ready to do it yet, but we're going to try it out. Not everybody's like that, and so that's important to recognize. If you're expecting transformation to happen overnight, that's not going to happen, obviously. But also, you've got to be thinking about how you're going to account for some of those practices in the tail. The other thing that we heard was that there are some biases built in towards larger practices. They have more access to capital to make some of these investments. They have more management structure in place to do things like even just keep track of all the payment models that are out there that they can participate in. So there's obviously some drawbacks to that, and so we need to find a way to make this work for some of the smaller practices as well as the larger practices. And there's a few models out there for how to do it, but I would say, you know, looking across the landscape, haven't quite figured that one out yet, and that's important to keep in mind. This is another point. I think David made this point well, that we're still, getting back to my first slide, we're still in an environment where fee-for-service is kind of the predominant thing here. And we need to figure out how to navigate between the systems. So we could learn to do what this guy's doing and ride the two horses, but eventually you probably want to get on one horse. We got to figure out how we get from the fee-for-service environment through to transition to alternative payment models, and then ultimately to the tipping point where the alternative payment models are now the payment models and driving the show. So as you plot out your path here in Delaware, you know, keep that very much in mind. There's different ways it can manifest itself. Within organizations, what we found was, even though maybe they're accepting alternative payment models at the organization level, at the front line, people are still being rewarded based on the number of patients or number of RVUs that they see. So it's not really working in the same way. Or it could be the example David gave of the CFO happy with what they see, happy from the grant, but then losing money on the flip side. Or it could be what Josh pointed out, where you have the physicians that are working by one set of incentives and the hospital by another. So there's coordination that's needed there. In terms of lessons learned, a few things we heard over and over from the physician practices that I think are things that could be easily addressed here in Delaware. So I want to go through those. One is just a recognition that these models are overwhelmingly complex. If you really dig in, it takes a lot just to understand what's going on. And at a practice level, it could take a manager almost full-time just to keep track of the different models and compliance with the different models. So try to keep it simple to the extent you can, okay? And the other flip side of that is, in any complex system, there are going to be errors. And you need to plan for that, right? I mean, that's okay. Some mistakes are okay, but it needs to be part of the planning process. What we heard from the physician practices was it really sapped their enthusiasm for this when they found out that they had to pay back part of their bonus because it was actually based on a mathematical error, or that the quality measure had a fundamental problem in it and wasn't really reflecting good quality. So those things will happen. I've recognized on the flip side, there's a lot of time pressure to rush these things out. If possible, build in a dress rehearsal. If you can't do a dress rehearsal, at least have an error detection, reporting, remediation system built into this, recognizing that there are going to be mistakes that are made and just need to catch them and find out how to way to fix them. The second is the multiplicity of performance measures. And we hear that that can really distract from actually changing patient care. I saw some reference to a common scorecard early on, so you might be all over this. But the second thing to keep in mind here is, to the extent you can, harmonize across models in Delaware, harmonize with the national level. And the third thing is, what can really dampen enthusiasm for these models is a lack of control, a perceived lack of control. It could be something like, well, I had a cost target for this year, then the new specialty drugs get introduced. It's impossible to meet the cost driver. That will undermine all the incentives you're trying to create here. But to generalize on that more, I think a fundamental challenge for you all, and one thing you really want to, it seems like you have a good start on, is to make sure you're all on the same page in terms of accountability. These models, what they are fundamentally, is a change in an understanding of who's accountable for what. When Josh was up here saying, the rural hospital CEOs in there has a totally different idea about what their job is, there was a fundamental change in accountability that underpinned that. And they were on board with that, and that's great. When there's more players involved, there's going to be some tough discussions that happen, but that's fundamental to all this happening, is having a shared understanding of that going in among not just the leaders, but also with the front lines. So that, I hope, gives some practical things that you can work on. I'll just close by saying there's a lot of challenges. This stuff isn't easy. The status quo is not good either. So it's important when you're comparing it to. And there's a lot of good reasons to do this. I can't say that we have it figured out. I can walk in here and tell you exactly how to do it. So I applaud the effort that you're all putting into it, the fact that you're all here today, and hope to be a resource to you in any way I can moving forward. Thank you.
So we're going to keep this train moving right along, and I'm going to let Dr. Sanders come up and keep writing your questions down, so we'll have them for our question and answer session. And those of you that are submitting on Facebook Live, that's perfect. Just keep making your comments, and someone's tracking those for our question and answers when we're done.
Thank you. I'm Rob Saunders. I'm from Duke University, and I'm also glad to be here today. When Peter and I were talking about this session a couple weeks ago, we were trying to figure out how we would split up the different topics, and Peter said that he wanted to do the overview, so I said, that's great, I'll do the updates on recent events. So this is what's happened in the last 2 weeks, and these slides are accurate as of yesterday at 5 p.m. So I think that was the last time we had to make a change. So we have checked the news right before I stepped up here, and there's been no major news in the last hour. So I'm safe to continue on this. You did check Twitter. So today I'm going to give a quick overview of a little bit of federal health reform and how that might affect some of what is talking here. I'm going to try not to use as many acronyms, but there are a lot of them, so I'm going to show them on the slide, but I will try to use words wherever I can. And if I do slip to acronym speak, please stop me. Also talk a little bit about the Medicare payment formulas, specifically macro, which Peter touched on, but there's been some updates on that over the last couple of weeks, and so that hasn't made the news, and that might be useful to chat about as well. And then end by talking about, well, what are some of the implications for Delaware, and what does this all mean? So let's start off with where we are in health reform. So there has been a lot of activity about that over the last few months, but especially over the last couple of weeks. There was a bill that was passed by the House of Representatives in late May, the American Health Care Act, or ACA. Then there has also been a bill that was introduced last Thursday in the Senate, the Better Care Reconciliation Act, which I hear now is being called BICRA. This is what I'm calling it. That was introduced on Thursday. My group and I read that furiously all day on Thursday and Friday. And then, of course, the Congressional Budget Office came out with an estimate on Monday. And then it was pulled from consideration on Tuesday. So a lot going on, but still, it's worth knowing because there's a possibility that a new bill might be introduced on Friday, as well we know. So what does this mean for payment reform? Well, one of the big takeaways here is even though both of these bills are being advertised as full repeals of the Affordable Care Act, they're really not touching any of the payment reform sections of that legislation. So while the Affordable Care Act had a number of provisions in it that talked about payment reform, it established the Center for Medicare and Medicaid Innovations, which helped to introduce a variety, those 1,000 flowers blooming that Peter talked about, and introduced the Medicare ACO program, the Medicare Insurance Savings Program. None of these bills are anywhere touching any of that. So what this says is, even though there's a lot of controversy going on in the Hill, the payment reform pieces are still having some level of bipartisan support. And while everything else is fluid, that is a piece that seems to still have a lot of support, and the train is still moving, and you can still bet that that will keep moving forward. Now, but what else is in this type of legislation? This did not come out as well as I hoped. This is a graph from the CBO, and it particularly looks at Medicaid spending over the next 10 years. So what we're looking at over here is total Medicaid spending, and then we're looking over time. And this top dark blue is what would happen now, where the federal government and states split Medicare spending between the two. And the bottom line is what would happen under the Senate bill. And what you notice is the Senate bill is a lot lower than the current law. And what that means, though, is that some of that money has to come from somewhere, so that responsibility for funding, that accountability for funding, would go to the states. And so while Secretary Walker pointed out some of the budget pressures there now, this would intensify those types of budget pressures in the future. And it does it in 4 ways. One of the ways that the Senate bill does that is by establishing per capita caps on how much Medicaid will pay for different types of Medicaid patients. It also has less talked about block grant option, where it would transfer over accountability and the funding for Medicaid to the state in return for, I believe it's 5 years that you can sign up for the block grant. And that would give you flexibility, but you have to, learn to manage within that type of framework. There's also 2 other provisions in there that specifically may affect Delaware. So one provision actually specifically calls out high-cost states and gives the Secretary authority to reduce the federal government's Medicaid funding for higher-cost states by about either 0.5% to 2%, depending on the Secretary's discretion. And there's also, in future years, a more of a star rating system for Medicaid programs where Medicaid spending from the federal government will be reduced to a given state based on a series of quality measures to be determined and cost targets. So all of those together will affect Medicaid spending, and that all puts pressure on what you can do and what you need to do for your Medicaid program. So that's Medicaid. Let's talk a little bit about the individual market. So there's some pieces here specifically allowing funding for this to states to help stabilize and innovate with their individual market. And there's a sum of money that is available in the short term and in the longer term. And that could be used for some of these types of payment reform activities, although all of this is to be determined as legislation rolls out and implementation happens. What's kind of interesting and hasn't made the news as much is that, at least in the Senate legislation, there's an expanded scope for something called 1332 waivers. Now, if you're really steeped in federal health policy, you might remember that these types of waivers were started under the Affordable Care Act, and they were designed to give states a way to innovate. If they could cover as many people using this comprehensive coverage for the same amount of cost, then they could get this type of waiver and do whatever they wanted to. So for instance, Vermont was considering getting one of these types of waivers for a single payer system. In the legislation before the Senate right now, these type of waivers would be dramatically expanded, so they cover almost anything the state wants to do as long as it doesn't increase the federal deficit. And that would give a much larger sort of latitude to the states in what they can do. It does come with some strings in that I believe it's an 8-year requirement. So after you've entered into that waiver, you have to stick with that waiver for the next 8 years, and that can be a bit of a stricture if it turns out maybe there were unintended consequences or the like. But that also has an effect in what you may want to consider doing today. So just to summarize, where we are with the federal health reform proposal, not much on payment reform. There's going to be a lot of cost pressure on Medicaid. There's something going on with the individual market that could provide some opportunities, but there's also some other issues as well. And there's a lot more in this legislation that I didn't touch on because my focus today was trying to touch on the payment reform pieces. So that's the federal health policy side, our ACA. Let's go to our next acronym, which is the Medicare payment reform section. And so Peter gave a really great summary of where we are with MACRA. But in general, MACRA is moving along. So MACRA, as Peter noted, was a rare example of bipartisanship. Both Republicans and Democrats in the Congress voted for this legislation and wanted to see Medicare change to more of a paying for value type of scenario. There's been 1 year of experience where Medicare has produced regulations and tried the program. And as of last Tuesday, they've actually introduced what type of regulations they may want to do for the next year. These are still proposed, and so if you have thoughts or want to help shape that, this is a good time to share thoughts with CMS and with Medicare. But what the sort of big take home here is it shows a willingness to try to provide on-ramps for physicians as they're thinking about getting into this program. As Peter noted, a lot of these payment reforms are really complex. And as we found out from our show of hands earlier, there's a lot of uncertainty about what's in these programs. What does it do? What are we supposed to be doing? What do we have to report? And without proper on-ramps, there's a fear that there's going to be a big backlash from physicians and from other clinicians who feel overwhelmed by what's going on. So the current proposal that's out right now tries to provide more of that on-ramp. There's two sort of takeaways that are worth noting here. One takeaway is that the proposed rules exempt more physicians from these types of Medicare payments. On one hand, that can be a positive thing in that it's helping to sort of move things in a stepwise fashion so you're not overwhelming folks. On the other hand, if you're a state like Delaware who's trying to move toward a value-based payment, that means that many of your physicians aren't going to be part of this Medicare payment structure. And so a lot of those physicians are going to be straddled in two worlds still, where they're still getting fee-for-service payments under Medicare, and maybe they're moving toward those more value-based payments in a lot of the Medicaid and commercial payers in Delaware. So that is one challenge. One interesting part that happened in MACRA and is starting to be seen in these regulations is that they've established sort of an all-payer option to meet this sort of alternative payment model bonuses. So as Peter noted, if a physician participates in these alternative payment models, they get a 5% bonus, which is positive for the physician as they're trying to make that transition. And under MACRA law, most of that 5% would require their participation in some Medicare alternative payment model, have a certain amount of their funding tied up in that alternative payment model by Medicare. What this new regulation says is trying to allow more details about giving physicians credit if they participate in an alternative payment model with Medicare, with Medicaid, and with a lot of the commercial insurers, so that it recognizes that physicians are making those changes, and it's not just Medicare that's coming through, and that can also be a nice incentive as Delaware is thinking about making those changes with its Medicaid and commercial payers, that those physicians would get credit under this Medicare payment. So one last piece about MACRA that also doesn't get a lot of news coverage is something called, another fun acronym, the PTAC, which stands for the Physician-Focused Payment Model Technical Advisor Committee. They left a lot of letters out. And in short, what this recognized is that while we're making this transition to alternative payment models, there really aren't a lot of those alternative payment model options for specialist clinicians. So while there may be a number of options for primary care physicians, whether that's from a patient's medical home to ACOs, there are very few of such models for your specialists. And that's going to limit how well you can make that transition. So under MACRA, the Congress set up this new body whose whole job it is to try to scour out and find new alternative payment models that may be available for specialty clinicians. They just started late last year, accepting applications and then started to deliberate and look at new types of models. They've looked at 4, they've recommended 2 for to the Secretary of HHS to try to roll out as pilots in Medicare. 1 for GI clinicians for especially medical home for inflammatory bowel disease, and a second one that looks at bundle payments for surgeons. But this can also be a resource as Delaware is thinking about what types of alternative payment models you may want to roll out, because these deliberations are public and these types of, there's a library therefore of proposals that are out there. You can see what is being thought about nationally, what is the evidence that's out there. This is an opportunity to both innovate and learn and coordinate and align with others. So that's NACRA. And so lastly, I thought it was useful just to talk a little bit about some implications for Delaware. So when preparing for this talk, I was reading through some of the most recent RFPs and some of the DCHI work, the strategic plan and the like, and it was really heartening to see how many initiatives are either being thought of or are starting to be rolled out. And that's fantastic, that's great, that there's so much effort and energy that's going in play here. I think one of the challenges that's happening now is a little bit what I like to call APMitis. So while Delaware is thinking about alternative payment models, here are some of the alternative payment models that Medicare is thinking about in terms of accountable care organizations, in terms of bundle payments, in terms of medical homes, both for specialists and for primary care. And as Peter mentioned, there can be a little bit of feeling of overwhelmness from many physician practices. They go, I don't know what all of these acronyms are. What should I do? I have limited time. What should I focus on if I just have one thing? And of course the answer depends depending on that particular physician practice, but we need to help folks out figure out how to make sense of this maze. Another big challenge here is that there isn't convincing evidence. So as Peter showed, we have sort of mixed evidence in a variety of cases. This is a graph looking at accountable care organizations for Medicare. And what we show here is basically the cost. So if you're below the line, you're losing money. If you're above the line, you're saving money. And on this side, if we look sort of horizontally, we have sort of an aggregate quality score. So how well, what's sort of the average quality for that particular ACO. And the only thing you should notice from this is there's a whole bunch of dots and they don't converge anywhere. Now, what you really want is folks to be in the bottom, on the top right. You want them to be saving money and have really high quality. And there are, in fact, a number of folks that end up in that top quadrant of this graph. That folks that are saving money, they're doing good work, they're redesigning care, and this model clearly works for them. There's also, however, folks over here who are really struggling, and that maybe this model isn't the right one for them. Maybe that's not the local practice environment they have, maybe that's not the way that their physicians work together, and we need more evidence to know, well, how do you know which group is going to succeed in this type of model, and maybe which ones need to try something else, or would be better suited in a different type of model. And part of the challenge here is that this is all very hard. So it's very, it's not easy, but the payment model is really just the first step. The hard part is after you start rolling out these new types of alternative payment models, because then some type of clinician group, hospital, and like has to go out and actually redesign all of their care processes. And that means they have to have governance that's on board. That means they have to have a culture in that organization that feels that they can go forth and innovate and try new things. That means they have to have new IT systems, or IT systems that can start identifying where are your high-risk patients, who we really need to worry about. It also means having new capabilities to do care coordination, possibly hiring a new care coordinator who can call up, say, your diabetic patients and say, I haven't seen you here for the last year, and the last time you were here, your A1C was above 10, so we really need to have you come back in. All of that takes energy, it takes time, it takes resources, it takes investment. And therefore, we can't think of this as just being, we start by making the incentive. You have to think of this as a journey and a partnership where folks work together to make the true transition. And so I think the final piece here that I wanted to raise is the goal is shouldn't just be to add a lot more payment models, but think about how we can support clinician practices, healthcare organizations, hospitals, as we make this type of transition. So let's just sort of end it, I think, sort of in 3 levels of recommendation. One of the key recommendations I think that we hear a lot is the need for alignment. As Peter noted, many people feel overwhelmed by the number of quality measures that are out there, often conflicting quality measures, and Therefore, the more that we can align these types of quality measures, the more we can align these payment models so that we help folks know that we're all rowing in the same direction. We help folks know where that goalpost is and folks can move toward that area. And hopefully that can reduce some of the burnout that we're really hearing about among physicians nowadays, with burnout rates approaching 50% in some places. Another big piece here is education. So helping to make sense of what is macro, what is NIPS, and what do you need to do right now in terms of submitting new data in order to make sure that you're succeeding at NIPS or able to succeed at these new alternative payment models. It's fantastic that what DCHI is doing in terms of helping to educate clinicians in terms of macro, and I encourage you to keep that up and to recognize that you're going to have folks at different levels. Some folks who have heard what this is, what all of this is, and have started down this path. Other folks who are just starting, and they're going to need different levels of support. And finally, there's a need for evidence. So as you're starting to roll out some of these new alternative payment models, I encourage you to think about ways that you can embed either studies or other types of evaluations in place. So at the end of it, you know, this worked, but not just this worked, but this worked for this type of practice and it worked under these conditions. So not only can you share that with other states, but also you can adjust your models as you go and start to think about where you can build on the work that you're doing. So let me stop there, and I think Peter and I will be happy to answer any questions you might have.
It's your turn. Do we have any questions? Yes, go ahead.
How are we defining a high-risk patient? Are we talking about it in terms of cost to the system, whatever that might happen to be? Are we talking about it in terms of their likelihood of being hospitalized? Are we talking about them in terms of they're likely to die quickly? And that's not just for you, but I mean, you know, we talk about high-risk patients all the time, but we don't truly define exactly.
I can take a first stab and then love to hear what others think as well. And I think you're raising a really important point, which is there is no universal definition of high-risk patient. And frankly, it depends. I mean, I think what you raised in the first part is we're pretty clear that there's a group of patients who have severe medical needs, and oftentimes that severe medical needs means that they end up needing a large amount of health expenditures on them. And so there is clearly some cost pressure to make sure that you're managing those patients well. But identifying those patients and identifying those patients over time is really hard. Sometimes it's looking at how many chronic diseases a particular patient has. Sometimes it's trying to figure out the potential to end up in hospital, or after being discharged from the hospital, potential to end up back in the hospital. And so you're seeing a lot of different measures out there that are trying to capture high-risk patients, but they're all capturing it in different ways. And honestly, I think this is one of the challenges that we hear when you start to see groups transition into alternative payment models, is the ability to have a data system, an electronic health record, and really just know their patients well enough to know who those high-risk patients are. Because oftentimes the physicians will know deep down, but the ability to form a list and then be able to talk with those patients and say, you know, what's going on? Is it because you have medical needs? Is it that there's social needs? Really being able to identify that can be important. So I think you're right, there's a variety of definitions. It's hard to do, but if we're going to succeed in any of this type of work, we're going to have to be able to really help that category of patients out more than we are now.
I don't have much to add to that. You can't answer that question because there's no such thing as a high-risk patient. You need to first agree what it is that you care about, and then you can get to high-risk for what. So I can't answer the question, but I can say that is a question that we need to be addressing in any endeavor that we pursue.
Microphones are coming. I see we have a few in the back. Dolores is heading back that way. Perfect.
I just wanted to perhaps like to get your opinion and for group feedback on chronic care management. ability to bill for that, and how this might be a critical link between care coordination, clinical settings and community settings. And I think that then links and speaks to the ability to pull in community pharmacy and other assets. So that's the first part. Can we comment on CCM as a tool for us in payment reform and restructuring delivery of care? The second piece, just an observation, I would suggest that the secret sauce in PCMH is community-based care coordination and addressing social determinants of health. And there's some very nice national models out on that.
So CCM, I think it's a good thing to have in the toolbox. The way this is set up right now in Medicare, there is a code that can be billed, but if you're participating in CPC Plus, which is their main or Next Gen ACO, you can't bill for the CCM. But I think there's enough evidence that care management is an important function that was not billable. Certainly, I think it meets the standards that they put out for other new codes in terms of effectiveness. They've made that decision to put that out there. I think it's an important tool in the toolbox. I think the thing that we don't have the answer to is it better to go that way or to try to get everybody to more of a medical home type model? And I think they were right to sort of not try to answer that right now, and we're trying to for the time being. For as much as fee-for-service is maligned, it's important to recognize it's not going away. These codes are out there, they're going to still be out there, so we might as well make it better. The latest estimate I saw was about half of what physicians do is not actually billable. So the idea that payments all linked to effort and doing more, only half of the payments actually, only half of the effort is actually linked to payment. Your second question was around community health workers.
So I think you're also bringing up a good point with community health workers in that when we've seen groups that have successfully redesigned their care models, it's not just by taking the current model they had and trying to be more efficient with that, although sometimes that can work. The folks who have really gone full in and started to make sure they've got a team ready to help, such as involving community health workers, have really been the folks that will make some of the largest gains. So that's been an important aspect that we've seen in a lot of our case studies and a lot of what we've been hearing out in the field of being able to use different types of folks. And it doesn't require necessarily a deep clinical background. It requires somebody who's able to call patients and empathize and say, okay, you just got out of the hospital, we can tell you're having some trouble right now, tell me what's going on. And just having somebody that folks trust and can talk to often is what you need to help make sure that folks stay out of the hospital again.
I want to add one thing on that, which was I think you're onto something there. I think there's some really interesting models out there. I don't know that they've been demonstrated to be the silver bullet, but I think a couple points. One is a lot of times we fall into a trap of talking about these payment models in terms of an incentive that we're paying to a provider to do a certain thing, and that I think can lead us down a road toward where it's just kind of following the carrot. I prefer to think about it or teaching to the test is another way to think about it. I prefer to think about it as, let's find a way to provide flexibility for people to do things that they think may work or they know will work. I've seen some really interesting models out there in terms of we're working with a medical school in Florida that is training physicians in a totally different way where they go to the patient's houses and they're treating not just the patient, they're treating the whole family. They teach them if they have diabetes, they're teaching them all how to shop for food together. Did you want to follow up?
Yeah, no, I just wanted to make a point. Not all CHW strategies are fee-for-service. There is, in fact, a performance-based pay-for-performance model, Happiness Hub model. And so this is rewarding clinical outcomes and reduction in costs, not I spent X hours on the phone. So I just want to make sure that folks in the room understand there are pay-for-performance, community-based care coordination models where Medicaid MCOs and ACOs are willing to pay based on RVUs. So I do just want us to be broad in our thinking.
Thank you for sharing that. And I think we have another question right up here.
Awesome. I'm the medical director of a large ACO here in Delaware, so a lot of stuff is really relevant. I appreciate it. First of all, thank you both of you for a very sobering and very honest appraisal of sort of what I think is really an existential threat to primary care in particular, but probably private practice in general, both the financial, administrative, and bureaucratic pieces that are there. So thank you for detailing it and having the right attitude as you do that. I think you reflect
reflected that accurately, the pressure. A very interesting debate nationally about the value of bundled payments and using that as a lever, particularly in the context of the APMs for specialists, versus using population health-based payment approaches. And they're very different. They can be competing. I think there's a sense that the bundled payment, the specialist approach, can sort of reward and perpetuate underlying inequities in the payment system that are there. But there's also obvious potential to decrease cost in high value or high volume and high cost areas. So maybe a little bit of enlightenment there on how you see these things coming together. Are they going to continue to compete or can they sort of find a place together, or do we hopefully have population health models win? You can see my bias.
So, and I think, as we're looking at some of these new payment reforms, what most of the evidence that I've seen so far on bundles has found is that bundles tend to help people be very efficient inside that bundle. So you do a bundle for knee surgery, then folks get very efficient inside that knee surgery. The downside is folks may then do a lot more knee surgeries because they get more bundles. There is, however, a lot of advantage to ACOs in terms of those population-based payments, but you may not see as much of that focused effort on, well, let's redesign that particular care pathway because it's so broad. You've got to look at everything. One of the big challenges right now, and I think it's especially true in CMS, is how do these things play well together? So for instance, when you have an ACO, and let's say you're part of a group that is under one of the mandatory areas for like comprehensive joint replacement bundle. So how do those two work together? And oftentimes it's the bundle eats first, and so the bundle gets the shared savings. But then that means that you're not going to do as well on your ACO. So even though you're reducing cost overall, under this, you're going to be winning in one case, losing in the other, and it can be really frustrating. And I know CMS is trying to think how these might work well together. We're not quite there yet. And it gets to the flowers. The flowers may be blooming, but maybe they don't like each other. So we're having some trouble.
Yeah, what's a flower and what's a weed? I'm a believer, though. I think there's room for both. I think so. On bundles, I think the advantages are people can get their heads around where to start, in a really concrete way. But there's still a lot of work to be done there. So I had experience with some of the very first bundles, going in and evaluating those and seeing what was happening. And it was eye-opening that the surgeons would see their data, and they had no idea what was happening to the patients. I mean, their view was, my job is to treat the patient in the best possible way while they're here, and then discharge them. And if you ask them, well, where they discharged, so they know where they recommended. They don't know where the patients went. They don't know what happened unless they come back. And I think going through that process, one is just a way to engage specialists, which I think there's a challenge in how to do that within these, and two gives you something very concrete where we can redesign care in these areas, some of which are very high volume. That said, I think there's a limited role for it, in which I think there's some people out there that want to bundle everything. I think it's better for things that are discrete, where you can easily identify the beginning and the end of the bundle, and where there's a mechanism in place like an ACO that can get at the idea that we just don't want people out there just then generating more bundles.
Awesome. So we're going to take two more questions, one from our room and one from our Facebook Live after we finish the in the room question.
One of the comments I'd like to make is that we're spending a lot of time talking about prevention as well as treatment, and I'm wondering, has anyone considered overlaying the wellness center model over the healthcare system? I think it's worked quite well. It saved lots of money, and it works. The next thing I'd just like to comment on is I've never heard anyone talk about the true fat in the system, and that is the burden that the healthcare system is putting onto the private practice provider in terms of verifying benefits and establishing whether or not someone has a benefit, and then fighting for months to be paid. And I think once we can solve those actual real problems, we won't have half the problems because we'll actually have the time to care for the people.
Perfect. Oh, this is a great segue. This keeps happening.
So on the prior authorizations issue, part of what our Medicaid Next Gen ACO is testing is elimination of prior auths for patients and providers who are using the next gen ACO. So there's some operational challenges, so that, because obviously you need to know which patient is in, so I think they're working through that. But that's one way that we've been looking to reduce that prior authorization burden in Vermont.
I appreciate the comments on recognizing the wellness center approach. So that's perfect, and using the things that have been successful in the past, I think are really important learns for us as we look at what can be successful here in Delaware. And our Facebook question?
This question, oh sorry, this is for David, I believe. How does the Massachusetts Health Policy Commission balance their investments in innovation such as innovators that can bring the best ideas to scale, but also in a way the right challenges are being addressed? Sorry.
Great. Thank you, Facebook, for that question. As we've been thinking about where we have kind of limited public dollars to be able to do some grant funding and innovation funding in the healthcare system, to be able to test some of these care delivery models that we've been talking about today, ways of using the care team differently, getting care out into the community. I think we have been very thoughtful in trying to say, like many grant programs have this challenge of what happens when the money goes away. And so we've been thinking about what is the sustainability for these innovations in the long term? What is the sustainability for being able to have this community-based care team focused on reducing readmissions and addressing behavioral health needs and social determinants of health? And in many cases, payment reform is that sustainability path. And it's exactly as it was framed earlier, that really this is about trying to provide more flexibility for the healthcare system to be able to meet the needs of their patients and deliver care in a different way. And as we've thought about our grant programs, in many cases, when we think about innovation in healthcare, we are not doing grant programs to test new lasers or to test new imaging. What we're talking about in terms of innovation is taking what has been proven again and again in many different places that has a strong evidence base and adapting it for new populations. And so it is around kind of translating more of that team-based focus of care. That's the innovation that we're trying to fund and support and test and evaluate, not necessarily a new piece of technology that you wear. And so it really is focused on kind of the care delivery side. But as always, we need that sustainability model or else we'll lose some of the gains we've made. So thank you.
Due to our focus on quality and efficiency, we actually have time to take one more question that is coming to us virtually. So congratulations to the audience, and I hear we have one more Facebook.
All right, we do have one more Facebook question. This comes from Deborah, and it's related to patient the quality care. When you speak about quality care, are you speaking of computer data that is coded by physicians as the measure of good health care? Are you speaking of treatment outcomes? And if so, how is that measured?
So in a prior life before I came to Duke, I worked for a place called the National Quality Forum that helps basically endorse specific measures for healthcare quality. And I think what you're reaching on is a big challenge that's happening in healthcare measurement. Because eventually, in order for this to all be real, you need something that can be put into a computer, because it has to go somewhere and then it has to be able to be quantified and put into a payment model. The challenge is not everything that can be measured really matters. And so there's a lot of treatment outcomes that we really want to know about. And what you really want to know is, after a knee surgery, could somebody walk? Could they go and do the activities they really wanted to do? Maybe they wanted to play with their grandkids. Maybe they were a runner and wanted to get back out there. Those are much harder, and I think that's a challenge we are right now in this stage of the journey, is that a lot of the measures we have are very process-focused, things that we can have data on and that we can do something with. Eventually, of course, you want to move to that phase where you're really capturing how is somebody doing? Are they able to do the activities of their life that they wanted to do? Is healthcare helping them get there? And we're not there yet. And the hope is someday we will, but it's going to take a little time.
Yeah, just a couple things to add. One is, my colleagues at Rand have been working on this for a long time. When they started working on it 40 years ago, people questioned whether it was possible to measure quality at all. They thought it was something that was so multifaceted and so sort of ethereal that maybe you knew it when you saw it, but you can't measure it. And I think we've shown that that's not entirely true, although we can't do it perfectly. I think there's a couple aspects of it that are really important, that are hard, but important, that haven't been mentioned yet. One is asking the patients what their experience of care was, and the other is asking patients if they were able to achieve their goals. So in terms of the health outcomes, either asking them about it or measuring it from them in some way. And I think we're working really hard on the methods to be able to do that, and I think that could really revolutionize what we're able to do.
And I am very impressed with this group because we were able to conclude our speakers' comments at 4 o'clock by my watch. So I'm going to ask you to sit tight for just a couple of minutes. And Laura and Julaine from HCC and DCHI will close us out.
Thank you. Thank you so much. So I get the awesome task of thanking everyone for being here, for expressing our thanks to DCHI for being a fantastic partner as we go through the journey of health reform in our state. And of course to all of our speakers who have brought us so much knowledge and interesting things to think about and to see how we can take the best pieces of what's worked and learn from the challenges that you've had in your states and really find the thing that's going to work for us in Delaware. So on behalf of everyone, on behalf of Secretary Walker, thank you so much for participating with us today and for being here. And then I have a really boring task of housekeeping. So you got a survey that was handed out. I believe everyone received one. If you didn't, please raise your hand and someone on the way out will get a survey to you. But this is a component of what we're doing under our state innovation model cooperative agreement work, is to evaluate what we're doing and to understand how you as our stakeholders and part of our healthcare system are feeling and thinking about what we're doing and how we're doing. So I would really encourage you to take the survey, spend a few minutes. I know it's a couple of pages, but it's really important for us to gather that feedback and that information. I believe it'll also be coming out electronically by email, so watch your emails because, of course, we have all of your email addresses, so we'll be contacting you, and you're probably on some list now. So please watch out for that, but if you're able to participate in that survey, please do. So that's the end of my comments, and I'll turn the mic over to Julie.
I'll just exchange with you. And I have the task of just trying not to hold you much longer. So I really do just want to echo my thanks on behalf of DCHI to all of our speakers, and as well as to our moderators, and also to all of you for your participation and for being here today. And I also just want to especially, again, just to reiterate what a great partnership it was in working with on this with HCC and as well as with the Department of Health. And I also will be remiss if I do not thank Shebra and Dolores for all of their support in making sure that everything was in place and coordinated. And I will end with just saying that it has been a full afternoon, but it is one that I hope that has been thought-provoking enough that we're going to come up with great ideas and opportunities about how to work together to accelerate our efforts toward value-based payment. And our next steps, simply put, is just to move from the what to the how. That is not original. I'm borrowing those words from Secretary Walker. But it is really important for all of us to remain engaged and to continue our investment in helping us to accelerate on our journey so that we're able to overcome some of the challenges but also able to grasp the opportunities that we've heard here today. And then finally, I just want to ask you to please do respond to the survey that Laura mentioned. There's a box over there, and you can drop it off there. But in addition, there will be a survey that you will receive, since we do have your email addresses on the web regarding this meeting today. I ask that you please complete it and return it to us, and you will be hearing more from us regarding next steps. And the final task I have is that someone has asked to make sure that you do pick up your free gifts from the desk. There are lunch bags there from Choose Health. And I see one hand that is persistently up.
I just wanted to know if the slides were going to be.
Yes, thank you very much. The slides will be available on the website. Thank you. Have a wonderful afternoon, and thank you all.